Good morning, everybody. I welcome you all on behalf of East India Fertility Conclave 2025 for the workshop of ART and Advanced Embryology. From basic IVF procedure to advanced techniques like embryo freezing, genetic testing, lapse imaging, the journey of IVF have been remarkable. IVF is witnessing unprecedented advancement that aim to increase accuracy, decrease risk, and make treatment more patient-centric. So I would like to call upon stage Dr. Parag Nandi, our first convener, to give a short speech regarding embryology. Dr. Parag Nandi, come on stage. He is Chief Clinical Embryologist, Cradle Fertility Center.
Hello, I am the convener of this conference along with Dr. S.M. Rahman, and I am the chairperson of this session. So, myself, Dr. Parag Nandi, welcome you all, and I would like to call upon stage Dr. Charudat Joshi. He and Dr. Falguni Patro, the second person who will be giving talk, and the first talk would be given by Dr. Charudat Joshi, who is a renowned embryologist, we all know, and he is the chairman of National Isar Embryology. And let me just open his CV. Yes, he is the medical director of Genes India ART Bank, a renowned ART bank run in Indore. And he has 30 years of experience, because IVF have started. The first IVF baby is now 47, and he is having 30 years, almost the starting time. He has been working in embryology lab. He has huge experience in this embryology field, and he has enormous publication, lots of book chapters. We all have gone through his book chapters and lots of publications in international journals. And his achievements, various posts hold in different ART societies. He was the, I think Dr. Charudat Joshi, you were the third ACE president. He was the Academy of Clinical Embryologists, started in 2011. He was the third president of ACE India. And presently he is holding post of chairperson in Isar Embryology, what I said, and his specialty is embryology and vitrification. Beyond this CV, I would like to thank him that for coming from the Indore long way and giving the lecture and enlightening us with his experience, and he will be delivering the talk on, just a minute, he will be delivering the talk on maintaining functional ART lab. That's very important. Thank you, Pitan. That's very important. And he will be enlightening us how to run a sustainable functional ART lab. So over to you, Dr. Charudat Joshi. The stage is yours.
So, very good morning to all, and I would like to thank Isar Bengal, Parag, and Dr. Rahman to give me this opportunity to deliver this talk in front of you on ART lab. Now, we all know basically any IVF center or any ART center is performed on basis of what kind of lab structure, what kind of infrastructure they have, and depending on that, the outcome, that is the percentage of success rate, comes in picture. What kind of instruments you have, where it is located, where it is set up, what kind of filtration system, what kind of quality control you have in the lab. So in this talk, we'll try to cover what is minimum requirement and how we are going to deal with it. So Infertility, as you know, this is a very common problem in today's scene, and anywhere, even if I look around 3-4 people of my known families, and I found one of them are suffering with this infertility problem. So it is very common problem now, and social, psychological, emotional stress, stigma, this we all know that any infertility patient has to go through this all parameters. So many factors are involved like lifestyle, work stress, delaying conception, etc. We also know that this is not only a natural process or auto-generated process. We are also having our system, different system working. What we eat, how we live, what is our lifestyle. This all make an impact on your fertility potential. And situation is becoming more complicated day by day. Now, as I said, present situation, if you see in your surrounding only, you will find infertile couple, and many factors are involved and needs to be considered for approaching treatment of this problem. Now see, here we have to understand first what is the problem, why this infertility is there, and accordingly the treatment is planned for that particular patient. You cannot offer everything common to all infertility patients. One thing is common in all factors, that treatment needs help of ART techniques offered by ART center for the treatment. Hello. Hello. Yeah. So that is why the ART center and particularly ART lab becomes most important part of this entire system, because ART is a broad term, but when it comes to ART lab, you are in a place where you are going to offer highly specialized techniques to be utilized for the conception of that infertile couple. So this slide shows that this is the requirement of the day. This, I don't know how many of you know, but this recruitment and accreditation and enrollment of ART labs in India started way back in 2000, and there were many efforts made to enroll these ART centers so that we know the exact position, what is the present scene in India as far as ART centers and infertility is concerned, because it is estimated that we are doing almost 10,000 cycles a year. But because it is not documented, it is not reported where it is done, so we are lacking with the data and all. So with this new ART law and registration mandatory and all these things, we have data of around 3,500 ART centers officially, but still I feel that there are more than these 3,500 centers working, which needs to get registered and accredited with this ART law. So this is why this many number of centers are coming, because number of infertility cases is also increasing, and to treat them the requirement is there, and that's why this lots of centers are coming up. And that is why another important aspect in setting up of an IVF lab in today's scene is that you have to see the future of another 10 years, because this is going to increase exponentially, and you have to have that provision right now to expand your setup in future, depending upon the number of cases. So ART lab is an essential and integral part of any ART technique, and it is real hope for these patients. The journey of life in form of embryo starts from ART lab. Thus, running an ART lab efficiently is also very important. Now, why I brought this point is here, because see, now everything is available. Finances are very easily available. All recent gadgets are available. All latest techniques is available. You can procure all of them. But then how you are implementing it and how it is benefiting your patient, that also needs to be taken care of. You have world's best instrument, but if you don't have proper operating system in place, proper operating person in place, you are not going to get outcome out of it. So training, staff, this all, we will discuss this, this all comes in picture. Just not having the instruments is enough for having a good ART lab. And success rate of the lab also important, as lot of competition is there, and this is source for those patients who has very low reservoir and unuseful gametes. Now, what this point says is, you have to prove yourself, because you see there is lot of competition. In area of around 5 kilometers, you will find there are 5 centers. So unless until you produce results, you give outcome, sustaining this ART center is very difficult. So that is what is the situation today. Now, a little bit about this law, I am sure everyone is aware of it. In this bill, they have categorized ART centers into four categories. One is level 1 clinic, level 2 clinic, surrogacy clinic, ART bank. Level 1 clinic, very simple to understand, can do up to procedure like IUI. They can do, the surprising part is that they cannot do the stimulation with the gonadotropin, which I feel which is absolutely wrong thing, because they are also qualified gynecologists. But as per this thing, they are not supposed to do the stimulation with the gonadotropins. Level 2 clinic is an ART center where all facilities are available under one roof. You can perform all the procedures. If you want to do surrogacy, you need to register separately with the authorities, and then you have to have a license for running an surrogacy clinic also. And then the fourth entity is ART bank, where donor gametes are provided, donors are recruited, donors are screened, and then they go to the place where their case is to be done. So I will just keep it. Now, in designing a lab, what factors you should consider? Expected workload. See, where you are located and where you are practicing, from that thing it starts, that what is the load of your lab, and accordingly you should make the basic infrastructure. If you are performing 5 cases a month, then you need a different kind of requirements. If you are performing 50 cases a month, you need a better and higher instrumentation and a better quality in the lab setup. You have to see in which area you are located. If it is a construction site, you need to take more care, because that is going to create more problem with your air quality. You have to see the future plan of that area also, like master plan. Every 10 years, 15 years, there is a master plan implemented, and there are lots of changes made. So today you may not know that there is a flyover coming up, but after 5 years of running your center, you will see that there is a flyover or there is a big construction coming up in master plan. Then that may create problems. So we have to see that from that angle also while designing your lab in the beginning. Then future expansion, and then guidelines for governing bodies can play important role. Now, it's very simple for we people to understand. Everything is written in the guidelines in the law. What area you need, what kind of lab you need, what kind of instruments you need, basic minimum requirement for running an ART center, it is written. So below that you cannot do anything. You have to have that basic infrastructure in place for running an ART center. Now, these are some guidelines about this. Total area, we are expecting around 1,000 to 1,500 square feet area, which can be divided into two parts. Sterile area, which usually is IVF, OT and your ART lab, and the non-sterile area, which may be the injection room, the counseling room, ultrasound, and OPD consultation. So in sterile area, as I said, OPU room, IVF XC lab, Embryology lab, cryopreservation room, ET room, IUI room. See, even in guidelines they have mentioned you have to have a separate ET room. Usually we don't have separate ET room, we do it in our OT only. But then ideally you should have a separate embryo transfer room nearby, so where you do only ET procedure. Then temporary storage, that is also in sterile area. This temporary storage means like you have boxes of disposable, but you cannot keep all of them inside the lab. You keep them outside, and as and when required, you keep on taking stuff out of it, and that is taken inside. Non-sterile area, I said utility room, storage room. ART setup is part of a multi-specialty hospital. Then preferably infertility OPD should be isolated. Now why? Because this is not a problem which is, they are not a disease person. This is a problem which they are facing and they may not want to discuss in front of or sitting with the common people, because it's a multi-speciality hospital, so you might be having all varieties of patients there. So ideally, infertility OPD or counseling should be done in a separate place, which should be an isolated place away from the normal people, so that they also feel comfortable while talking to you. Routine investigations and embryology setup can be a separate place, because every time sample patient whenever comes, we offer first the semen analysis. So this semen analysis can be done in an embryology lab which is outside your sterile premises. Routine work can be done there, but when you are doing any ART procedure, you can do it inside the lab premises. Location. What we want from IVF lab is, it should be away from the dust, it should be away from the pollution, it should be away from the vibrations. Now, if you have seen when you perform ICSI, even slight vibration going on anywhere surrounding, it causes problem with the needle. Needle also starts vibrating, which may cause damage to the oocytes while injection. So, what we do is we keep anti-vibration tables, but still it's a multi-speciality hospital, or it's a big building with a generator outside. So when that generator starts, that can also create vibration. So where it is located, your lab should be away from these vibrations, and you have to take all the precautions to get rid of this vibration. And then as I said, city planning, master plan has to consider first before setup. Air quality, very important. It all depends on where you are located. Probably nowadays we have more go for AHU, air handling unit. It's a compact unit which gives constant supply, circulation of a sterile fresh air coming inside the lab, so which is ideal. But you can have other options also. Positive pressure model is there. There is room filter system is also there, which keep on circulating the room air and filter it. Building material, now we have so many options available. Previously it was only the tiles and brickwork and all, but now we have modular concept there. So there is, everything is of stainless steel, it is easy to maintain, it is easy to clean, and it is easy to run. So ideally modular lab is an option nowadays available. But other than that, what point you should consider: non-porous material, minimum number of joints in between, and then there should be no VOC emitting substance in the construction material, and so on. Flooring, non-slippery, non-porous, vinyl flooring probably can be an option. Instrumentation, as it is state-of-art lab setup, it must have all necessary equipments. That is what I just suggested. They have mentioned in ART Act the minimum requirement of an ART lab, so that much has to be fulfilled. Then servicing, AMC, supplies, response of vendor should also be considered. If the point is that if suppose you are located in a remote place where services are not that easily available, you have to make sure that you should have the spare parts available with you. You should have someone nearby who can help you out with the breakdown. Comparative analysis should be done carefully with different aspects during selection of instruments. So everything, although what I feel as an embryologist is that instrument is a choice should be given to the embryologist, because ultimately he or she is the person who is working on that machine. So if I am not comfortable with some particular machine, and if I ask to perform on that particular machine, probably I may not give 100% outcome. So the consultation while deciding, embryologist should also be part of the lab instruments. Preference to be given to choice of lab director or lab person, that is what I am saying. Instrument should have provision of upgradation in future. Now this is another important aspect. Suppose in future we are talking about laser, or we are talking about something new technique which is coming up. If you have present setup which is non-upgradable, then you have to go for the entire new setup again, which may be very costly affair. But if you have that provision of addition in that particular present setup, it will be helpful, it will be cost effective. Periodic checkup of working performance of laboratory instrument in preferred for consistent results. Spare part availability should be ensured. These all are important parts of a lab setup. Just getting a modular lab will not work. You have to have everything related with your lab in place, in spare with you, so that at any time, if it is required, you can just use it and replace it. Designing and placing of the instruments in the lab should be done in such a way that it will cause minimum disturbance. Periodic checkups on performance, preferably pre-filters, HEPA filters, should be checked regularly. Calibrated measuring instrument is of great help in maintaining quality control in lab. Now, as I said, there is competition. There are so many centers nearby. They are all offering ART services. So what you need to do is you have to give your best. And quality control is one of very important aspect in ART lab, where you have to see the air quality or other parameters which can be monitored regularly, weekly, once in three months. And the best part is you should go for AMC. It should be done with an external agency, so they can do this job for you. You can get auditing also done with some external agency periodically. AMC and know your vendor. Now here, this I always emphasize that just getting the instrument is not enough. You have to have good rapport with the concerned person. Why? Because when you are performing and you come across some little bit glitches is there and some problem is there, you should be in position to talk to the concerned service engineer or service person. I am facing this problem, what can I do it now? Because he will come and then he will fix it, that's a different issue. But right now you are performing case and you are stuck up with something. So to get a temporary solution to it, you have to have a good rapport, because if you don't have that rapport, he or she may just refuse to, no, I am busy with some other work, I cannot talk. Then what you will do? So that is the point. Listen to the advices given. External audit at least once a year is of great help. Convenience. Lab area is main area with restricted entries. It is occupied with lab persons. Ample space should remain free for their movement. Now, initially, if you see the older labs, there are hardly 100 square feet, not even 100 square feet, lesser than 100 square feet, and you see they have make in ART law mandatory that there should be 2 lab persons working in the lab always. Minimum requirement is 2. Now, if you don't have that sufficient space, there is always a chance of getting them collide with each other or falling down something, because instruments are also there, movement is also there, so you should have ample space. You have to see the convenience. Location of the instruments, incubator, laminar flow, this also makes a lot of difference. Staff requirements, IVF lab director, embryologist, technician, nursing staff, OT staff, consultant, assistant to consultant, and a counselor. These are all minimum staff requirements in an ART setup, and they all should be qualified. Their qualification is also given nowadays in the law. They have to have that particular degree or certificate with that particular experience. Then only they can work. Now we have to understand ART lab setup. It's a teamwork. Good understanding among themselves is the key of success. Everyone should know their job responsibilities, and in case of non-performance, appropriate action can be taken. Qualified staff, importance of sterility, quality behavior, periodic upgrade on latest development is advisable. Now in ART setup, you have excellent instruments, you have excellent atmosphere, you have excellent quality control, but people working with you, if you don't have good understanding among them, that can also create a problem. So you should have an periodic meetings, you should have an internal meeting once a week or 15 days once in 15 days, and you should discuss about the cases going on, what we are going in next quarter, what we have done earlier, what is the result, is there any problem with some particular case, if you have seen something peculiar, you should be able to discuss. And everyone working in that setup, and I feel that that starts from even that sweeper, should understand the importance of cleaning, how to clean. Cleaning is very easy. You will just get any cloth and wipe it. but then with what detergent he or she has to clean it up, how it has to be cleaned up, that is also very important. SOP, this is one of the best. I suppose if you have standard operating procedure in place, so everyone has to follow. What is meaning of SOP? SOP is a document which is meant for a particular process, like for ICSI, dish preparation. So there will be a stepwise instruction on this SOP that I do, you do, anyone who is performing ICSI procedure and making the dish have to prepare dish as per that SOP only. If there is any change, a senior embryologist or lab director should make that changes after discussion, after what problem you are facing and how to rectify it. So that is very important document, SOP. You should all have this practice of SOP. Documentation, very important. Nowadays you are more responsible and more liable for offenses and punishment in this new act. Everything should be documented. And this documentation, I say, it starts from the OPD. How the patient who is coming in, there from their entry, it starts. Everything should be in who came, what is their address, contact number, this everything, who came inside lab, how many people enter, how many people go out of the lab and all. Everything, everywhere it should be documented, recorded, because that will help you in analyzing your performance only. That what kind of work you have done, everything if it is written, you can just sit with those documents and analyze it. That is the importance. Training, very important. You should keep your staff always updating with the new techniques coming up, new material coming up in the ART lab setup. They should not remain behind. So ART Act, we already discussed. This ART Act have a structure of national board, state board and then district board. Usually we are supposed to answerable to the district board. Then if something is problematic and you have to go, then you have to approach the state board. And then if it is not solved at state board level also, then there is few things which you can achieve at national board also. This one thing I just wanted to highlight here, anonymity and confidentiality. This is a controversial point in ART Act. Previously, as a donor, whenever donor is going there for any patient, the confidentiality, anonymity of the donor was the main point, that the couple should not know about the donor, who is the donor and from where it has come. But now they have converted it with the confidentiality. So the donor can be anyone, maybe a relative also, but then it is clinic and the bank responsibility to maintain the confidentiality of that particular person who is donating. So to conclude, new developments should always be welcome. Initial trouble, but soon it will be streamlined. We all know of PCPNDT. Initially when it came, so much of trouble was there, but now everything is smooth line. Similarly in this ART also, after a few years, everything will be streamlined. You are supposed to fill the data online every day on day-to-day basis as you are filling for PNDT. They are already in process of making this software, which soon will be available to all ART registered center, and they have to do the entries in that particular software. So with this I would like to thank and conclude my talk, and I would like to invite all of you for next upcoming conference of Isar Embryology, that is from 11th, 12th and 13th of September in beautiful city of Indore, the cleanest city of Indore. Thank you very much.
Thank you so much, Dr. Charudat Joshi, for delivering this very important talk about the crucial aspects of lab and how to maintain a sustainable and good quality lab. If you, all the attendees, I am asking that if you have any question, we can come at the last of the session. This session, second
speaker is Dr. Falguni Patro, and he is very well-known embryologist in all over India. He has worked in so many cities around India, and he is having more than 17 years of experience. He is the scientific director of Odigain Fertility Care, Cuttack, and he has been associated with many centers around Odisha and around other part of the India. He is having several publications in national and international journals, I know, and he is having he is right now organizing chairperson of ACE 2025, which will be in Bhubaneswar only in August, and he will be organizing that ACE conference. This is a national conference. I would be asking everybody to come in that conference, but for now I would be happy that if Dr. Falguni Patro deliver the talk on a very important aspect, that highest success in poor responder patients. Please, Dr. Falguni Patro, come and give the lecture on this. And if you have any question after this particular talk to Dr. Charudat Joshi or Dr. Falguni Patro, you can ask.
Very good morning to all. Thank you, East India Fertility Conclave. Within a one-day 10 workshop that's going to be taking places at the different place of Kolkata. It's a tremendous job, and the entire team is behind to make the entire program successful from last 1 month. So it's a nice experience for me to come to West Bengal, from where India got its first IVF, the test tube baby. And I also got my first talk in West Bengal for the first time here. So thank you very much. So this is my topic today that I'm going to cover on POR. We all know the poor ovarian reserve, and in India how common it is. That is also we all know. So I'm going to, as an embryologist, I'm just going to cover on the lab part of the thing, because I have very few experience on the clinical part. So before starting off my topic, I just want to take an audience comment. This is a blastocyst we have got from a patient, and we have only one blast. So should we transfer or not? This is my question. If we have only one and it is in this stage. Just I want to interact with the audience. This is the only one blast. Whether it's look like a blast, it is an early blast. So if we have no option, we should plan for it. And this is from a POR patient. In my next slide, I will show it. This is on day 0. We got only one egg. We thought what the call we should take, and we did a IVF. Day 1, there is no sign of fertilization and all. And day 2, I found something in 2 cell. So it is already 24-hour delay. So that's, I thought might be it is a parthenogenesis, so what I should do. But still, I culture it for the next, I thought I will culture for another 24 hours. Surprisingly, I found on day 2 it is in 4 cell, which is almost 24-hour delay. And on day 3, but actually from the pickup it is day 4, it came to 8 cell. And on day 6, it came like this. So sometimes we have to keep some of the experiment, how we are doing. And in my entire career, this is the only one case I got like this. Till now, if I'm culturing the GV with sperm, I'm unable to get a single blast. So in my 17 years of experience, if I have did nearly 15,000, 20,000 cases, only one case I got like this. So it's gave me a thing, whatever the things, keep trying. Whatever the result that we don't mind, we don't know, maybe it is a GV or something, so don't do something. But initial, when you are doing the screening, the crucial thing is to assess the cumulus. And after that, you should take a call. So that I will cover in the next. This is the before OPU day. We all know clinician has talked with the patient in which way we can do. We have the best setup, we have the best thing, and we are well expert. Embryologist team, when they have got, okay, we have 1 or 2 egg, it is a challenging case, and we are expecting a good blast, and a common feature for the patient, for clinician, and for embryologist to pray, let's just fertilize and give a blast. And suppose everything will go well, everyone will get the credit, but if something goes wrong, you have very less number of eggs, and something it is not fertilized, it will be cleavage arrest, then whom to blame? Clinician will say, is there any problem in the lab? From last 5 days, 6 days, everything is going fine, 10, 15 patient, everything is going fine. But in one case, how you can say there is some problem with lab? If any problem in lab, let me know. You have some query for the VOC, it's in the chart. If you have something on my scale from last 10 years, I am working with you. And this is our statistic results and all. Then something we might be end up, it is the patient factor. Aged patient, very less egg or something. But scientifically we should approach to our all things. So these are my content that I am going to cover. This is the definition of POR. Throughout the medical literature, if you are going, if 3 or fewer oocyte or follicles, E2 level below 500 pg per ml, fewer than 5 oocyte retrieved in higher gonadotrophin dose cycle. Most literature on poor responder has utilized at least 450 international unit of FSH, yet several studies in the 1990s confirmed no added benefit to gonadotrophin dosing above 450 IU or of HMG or FSH. If the more, then we know the POR egg will be more in granular stage. They might develop some of the morphological feature. There will be a pre-vitelline space will having that will be a bigger pre-vitelline space. Debris will be higher, and when we are doing the ICSI with very less number of eggs, so sometimes there will be no resistance, which is a common feature for every embryologist. After doing ICSI, there is no resistance. That means your cytoplasm is not mature, because after the sperm will be inside the cytoplasm or in the ooplasm, it is the cytoplasm to take a role to digest the sperm cap, so the DNA will come out. That is not in our hand. In our hand, to select a good sperm and to do a proper ICSI and to release the sperm inside the egg without damaging. Beyond that, it is the gamete. They will talk, they will interact, they will discuss. As per the ISHRI guideline, at least 2 of the following 3 features must be present: advanced maternal age, or any other risk factor for POR, a previous POR less than 3 oocyte with a conventional stimulation protocol, and abnormal ovarian reserve test. That is, the AFC should be 5 to 7 or the AMH 0.5 to 1.1. Now, what is the situation of India? ISHRI, ASRM, they are of their continent, but in India, around 30 to 40% of patients are going for POR, that we all know, very less follicle due to any of the factor. And in South, it is a very common. People are getting married at the age after 30, 35. So we know, because I have spent my maximum year in South, so I know the part of the thing with a severe male factor with very less number of. Nowadays, to get a 15 to 20 egg from a self patient, it is a miracle, except the donor. Donor we used to get very good. But as per the ART law, we can use only 7. But with a normal patient to get 15 egg, 20 egg, it is a challenging for the clinician. After the enforcement of the ART Act 2021, availability of the donor is a questionable, because West Bengal, Maharashtra, especially your Bombay, Delhi, Hyderabad, Bangalore, you know you have the people there. But the state like Odisha, where we are always dependent on the donor on the outside of Odisha, to get the donor, that to be on your time, and something how the stimulation is going on. They will send a scanning or something like that. That will happen used to previous from the ART law. But now as per the ART law, you have to stimulate the donor in the level 2 center. But to get a donor from outside of the state and to keep them in the center and to stimulate for 10 to 15 days, it's a very difficult task. Donors are not ready to stay. If they're planning to stay, they used to make a very good demand of money, then need this type of food, and if everything is going a burden for the patient. Availability of the registered bank, still now maximum I think 50 to 60% of bank has registered in the ART part. But 20 to 30% still they are dependent on the donor agency, not by a bank. Agent used to be their dealer. They will say, sir, we will send you, we have very good donor and thing. They will come to you, they will stay to you, something like that. But it is against the law. We should follow the ART law. And if this thing, before the ART law, suppose we used to get a donor at a cost of 70,000, 80,000, 1 lakh of a standard profile. Now the cost is very different. It is going 1.5 lakhs, 2 lakhs, only the donor cost. And now you have to add the lab cost, then the record maintenance and the legal issues. The lab option of POR, so whether we should do ICSI for all, PGT for all, ideal day of transfer, fresh versus frozen embryo transfer, because we have very less number of egg, resulting less number of embryos. So whether we have to do a fresh transfer, whether the embryo will recover or not, everything used to go in the mind. Or we should do a oocyte pulling and embryo banking. ICSI for low yield oocyte. Poor responder typically produce fewer than 5 eggs. In couples with poor ovarian response and fertilization failure, ICSI could have a potential advantage than IVF because it is having a higher fertilization rate. If either the oocyte appear immature depending on the cumulus, like I have shown in my previous slide, it is very essential for the embryologist, because as per my experience, I can say IVF is a challenge to embryologist because you don't know the oocyte quality or something. But ICSI is a challenge to clinician. You are denuding the cumulus, you know the egg, it is mature or not, how is the quality, and everything you can ask or you can discuss with your clinician. But in IVF, everything is blind. So it is the experience of the embryologist how he is going to take a call. I will go ahead for ICSI or for a IVF. If either the oocyte appear immature or the mature appearing oocyte immature after stripping, employing standard IVF for the remaining eggs, but the sperm parameter should be good. And nowadays, to get a sperm morphology more than 4% is another challenge for the male fertility. An oocyte is considered immature when it is surrounded by corona radiata with less dense cumulus for us, and you have to take a call between maturity and immature cumulus. Then you have to do a PGD or PGS or biopsy something for the genetic study, because you know POR used to come with a patient with higher age or something like that. Couples are at an increased risk of developing chromosomally abnormal embryo after unexplained repeated IVF failures or advanced maternal age. Therefore, PGS utilizing fish has been studied for patients with advanced maternal age, repeated miscarriage, repeated implantation failure, severe male infertility. Ideal day of transfer. Once again, it is a challenging. You know, on day 3, it is the 8-cell grade 1. Evening time, we used to take in our lab a call whether we will freeze or we will proceed for an extended culture up to day 5. In our lab, it is our standard SOP. If you have less number of embryos, don't freeze it in the morning, wait till the evening. Suppose you have did your ICSI in the morning timing. So by day 3, late evening, you can know after suppose a time of around 75 to 76 hours post ICSI. If something it is more than 10 to 12 cell or 12 to 14 cell or starting of your pre-compacted morula or something, you proceed for day 5. If it is same in the 8 cell in the morning, evening also it is the same 8 cell, then talk with the clinician, talk with the patient, freeze it and plan it for the next transfer or plan for a fresh embryo transfer, whatever the clinician and the team used to discuss and do. As a general rule, once the number of viable embryo is equal to the number of planned to be transferred, further delay of transfer is likely to be more harmful than beneficial. The clinical pregnancy rates per oocyte retrieval per embryo transfer were significantly higher in day 2 embryo transfer group compared to day 3. Still, depending on the embryo quality, day 5 also can be planned. As we all know, what are the number of embryos for transfer, indication for increasing the number of embryo transfer, advanced reproductive age, poor ovarian reserve, poor response. ASRM guidelines, women less than 35 year up to 2 embryo, women less than 38 up to 3 embryo, women more than 40, less than 41 up to 4 embryo. But our guideline is saying the ART Act of India, not more than 3 embryo to be transferred. Donor oocyte is recommended if the patient, they are okay with the donor eggs and all, because they want a pregnancy, they want a child. Recommended oocyte donation IVF only for poor responder. With multiple IVF, you have did 1 or 2 stimulation, duo stimulation, dual stimulation, double stimulation. Number of eggs is less or the quality is very bad and you are not getting your required number of blastocysts, donor is always a good option. Very poor prognosis group includes all patients over 43 years of age, any patient with an FSH over 15 mlu per ml, and undetectable MH. Oocyte banking, it is another option. Before the law, the bank used to supply, but now as per the law, the bank cannot stimulate, they cannot do the OPU and all this thing, so this is out of question. Only in the self we know if the patient is already very less egg, then there is no need to freezing unless the partner is not able to come to give the sperm. The process of synchronizing the recipient with the donor had some drawbacks, including waiting list, as we know, to get a donor and to wait for the patient for more than 1 month or 45 days. And with your competitor center, when you are working, as my previous speaker has told, in this area, suppose 5 to 6 center, if you are saying to your patient you have to wait for 1 month, the patient will go to another center because they have more advanced option of the corporate. With clear depletion of ovarian reserve, recurrent IVF failure, especially after multiple euploidy, then only option left is adoption or ovum donation. Now, few of the research point in POR might be some things are going on, some are in process, but not a very practical result has come. Intra-ovarian activation, ovarian tissue freezing, activation and reimplantation, stem cell or PRP injection in ovarian cortex, autologous mitochondrial transfer are still experimental. Intra-ovarian PRP, here what they used to do, infusion increase the ovarian reserve parameter resulting in increased mature oocyte yield, fertilization rate, as well as the formation of good quality embryos. There is a great need for future high quality randomized controlled trials to estimate its efficacy in terms of clinical pregnancy and live birth rate. Also, there is a need of identifying optimal level of serum AMH or another marker of ovarian reserve for the success of intra-ovarian PRP infusion and identify the subpopulation that would get the most benefit from PRP. I think the clinical people can say better on this. This is the mitochondrial transfer, which is on experimental studies. Here, a small biopsy from the ovarian tissue, isolation of egg precursor cells from the ovarian tissue, isolation of mitochondria from egg precursor cell, and injecting the mitochondria to mother's egg via XC. So, the conclusion point that I can say, number of newer procedures in ART that have a role in the management of poor responders. In vitro maturation sometimes is a good option that you should keep in mind. When you are doing, you know that these are the risks may come, the patient is going for stimulation for more than 12 days, 14 days, 15 days. Your clinician is trying their best to create the, to get the best follicle or the best egg. And suppose due to any of the call you have did the denudation or your egg is not mature, IVM is a very good option. But how practically it is, no one knows. Cryopreservation of oocytes, when the donor, the sperm parameter is not able to come or on that day is unable to give, because it is another challenge to freeze the egg, very less number of eggs, then you have to thaw it, you have to do XC and to create embryos. But nowadays with the very good media available commercial media, you can try. Embryos from multiple retrieval cycles. Suppose in the first cycle you got only one blast. Maybe that's not a very good grade. So it is always to counsel the patient before take up the treatment. Maybe we can do a 2-3 stimulation, and our goal to get at least 2 sets of good blasts so we can make a transfer and you can achieve a pregnancy. Success, what? It's not to make the patient beta hCG positive, we are happy. It's not. To give the patient with a healthy baby, that is a success. Cryopreservation of donor oocytes, egg banking, something which is not possible as per the ART law. Proper counseling of the patient with the risk associated with the procedure. So take home message, expect the unexpected things. I think in 2011, this in my every presentation I used to quote this dialogue. It's not of mine. Dr. Kurula George, he has came to my center when I was at Karnataka. He visited my lab, he asked me a few of the questions, he was so happy, and he told, in IVF, always expect the unexpected things. It's not what you have planned, it will go in this way. You are planning in this way, but if something will come, you should have a backup plan. Be prepared for the challenges with scientific approach. Inform the patient about all the potential limitation and influencing factors. It's not to get a patient for your commercial benefit or something like that. Say, this is the thing and we are going to this. I think most of the centers are doing. So thank you very much for your patient listening. Hope I have did the justice to my topic. Thank you.
Thank you so much, Dr. Falguni, for giving this nice lecture. Actually, Dr. Falguni is also the member of Odisha Appropriate Authority of ART. So he is having extensive knowledge on the ART law. So whatever he has said regarding the oocyte bank or sperm bank, that is really enlightening for all of us. And I think if you have any question, it should not be very, good question. If you have some question in your mind regarding this particular 2 topics, like one is the, a good lab management, and the second one is poor ovarian reserve or DOR, diminishing ovarian reserve, how to handle. If anything is available, that you can always ask. Yes, Dr. Falguni has said that we are, there are upcoming ovarian tissue cryopreservation and, mitochondrial transfer. Those things are there. Some ethical legality problems are there in practicing right now, but the research is going on. It should be, it should be there. I think within maybe 4 or 5 years that it is being practiced. ASRM or ASTRAE will be giving us the information about that. When you can practice that in your clinical practice and what is the SOP. That time we can try that thing. But for now, ovarian reserve, diminishing ovarian reserve or poor ovarian reserve patients handling in the lab under the microscope is really a challenge for all of us. We will agree to this particular point, and we have been trying to give the most whatever the possible way we can help those poor patients, those who are having not good number of eggs, because in our practice we always see within every 2-3 days we get this kind of DOR, POR, DOR like this. It is being written. So we are really facing this kind of problem. It is a problem of our society. We have to think in broader way also, like the the pollution challenge and adulteration and many things, heavy metals, everything is working behind the hygienicity, that all these things are working behind this kind of thing. That is another part, that how to overcome that thing, and another part is that how to overcome inside the lab. Once the egg is there, the egg is not looking good, and as he showed that kind of embryo slide, the first slide, it was really eye-opening, should be eye-opening for all of you, from my experience and everybody's experience who have been practicing for a long time, that sometimes it shows like it won't work out, but it works out. and we get baby. So unexpected thing happens every alternative day in IVF. So you have to be prepared. It's not a blame game, it's a team game. So be prepared for that. And if you have any question, whatever in your mind, you can ask, or else we will be proceeding to the next session. And in between, Dr. Shuparna is here from Isar committee. He is OC, she is OC of workshop, and she will be, saying to something, very specific for this workshop and all this Isar and everything, and will be giving, felicitating the, the national faculties who are here. So, if you have any question to the audience, please. Anything to the legal? Yes, please.
Both the speakers were excellent. Good morning. I'm Dr. Shuparna Bhattacharya. My first question is to Dr. Patro. Your presentation was very nice, very lucid. One question is, these poor responders, as you clearly said, they make less number of oocytes, less embryos. Now, when they come to us, they failed already in some place, and they are coming to us in our center. Now, when we are counseling them, they won't agree for donor. Now, the next time when you are again planning them out, since you stressed on the day 3 freezing, my question is, when they are coming to you for the second time or maybe the third time using their own gametes, will you still advise day 3 or will you wait for day 5?
Depending on the number of embryos, first I will see the report of the patient and the previous center, what is the report they have. If it is a day 2 or a day 3 embryo, it is a which grade or something they have planned for the transport. So from the previous report, that will
usually no reports have been given in the previous cycle. Many labs do not provide any reports to these patients, and they come to us, said they've told us this, they've told us that, and we've had a failure.
So in that case, in our lab, what we used to do after a PN will come, we used to check it 28 hours to see the early cleavage pattern. If it is symmetrical, then we used to check. So for those embryo, if we have a time lapse, in time lapse we used to do the annotation, day 2 the cleavage is proper or something like that. We used to proceed for in every 24 hours we used to take a call. If on day 2 they are 4 cell, very good grade or something, we used to wait for 24 hours. But from day 2 we know already the fragments has came, the 4 blastomere are not in equal shape, then we may take a call on day 2 with all the limitation we used to explain to the patient.
So you'll transfer on day 2?
Yes.
Okay. So day 3 also you won't take, and not
depending if it is a grade 1 or grade 2, still grade 2 we used to go to day 3, but if it is a grade 3 or something like that, depending, because we all know uterus is the best incubator that we all know. So give a chance to the patient and hope for the best. So that is the practical, because our clinician used to counsel from these are the outcome with day 2 and day 3. We will try to go ahead for day 5, but in some bad case or something, we may freeze on day 2. And if it is a frozen embryo transfer, if it is a fresh embryo transfer, then depending on every day's embryo stage, we used to take a call.
So irrespective of the previous failures, whatever you see on day 2 or day 3, you advise freezing or transfer, or you don't wait for the blastocyst.
If I have one embryo only, if I have at least 2, one is growing good, one is growing bad, then I will go from day 3 up to day 5, I can take a call. Day 3 evening, if the compaction pattern has started, embryo has went more than 8 cell, then definitely I will go for day 5.
Thank you so much.
Thank you.
3 junctions. Basically, he was saying like the syngamy, starting the syngamy. That time is very important. Another time is when the compaction is starting. That is what he was saying. And another time when the blastulation is starting. So these things will give us an idea, because every lab is not like fortunate that having a time lapse.
Right.
But
are you using routinely
yes,
time lapse?
Yes,
okay.
Regularly he is using time lapse. I have seen, I have gone to his lab. Time lapse gives this kind of, lots of data. But as an embryologist, be vigilant that whatever, if it's anything suspicious, have a look. It doesn't mean that every time you take out the embryo and see under microscope, it will itself spoil the game. So you have to have a very, syngamy when it is the 2-cell division is starting, when the compaction, is it a RD compaction on the day 3 evening, what you are saying, it's very important to see. This kind of things gives very good idea about that this particular embryo will be surviving or not. And the best, he said, like the uterus is the best place to give it back as soon as possible.
The question was from the clinician's part, not the embryological part. My question was like, do I tell the patient that it is a non-viable cycle, or just looking at it just for the sake of giving them a transfer, or just for the sake of giving them an embryo, do a day 2 or day 3? That was the question.
If it is a day 2 embryo, 4 cell with the cleavage pattern is poor, if it is a grade 3, success rate is very less. So you say to the patient, it's better to cancel.
Yes.
But if the patient wants, no, you go ahead with the transfer, I will just check in what will happen. So then it's a call of the patient. Proper things.
So it is both ways.
If day 2,
after
you have
counseling,
at least one grade 1. Go ahead up to day 3. Evening you check. If the compaction has started, go for day 5.
All right.
I slightly have different opinion, and I just simply.
I have a slightly different.
It's very simple to understand. What I mean to say is, it's embryologist's call to inform clinician about the status of the embryo. Now you have very limited choice, as you rightly said. Patient is denied for donor oocytes. Whatever is there, we have to give. So our aim should be give her best chance. It may be possible that you may not have good endometrium prepared in that particular cycle, irrespective of embryo quality. So what option you have? You have to freeze that embryo. And nowadays, advanced techniques are available, good media are available, survival rate is also very good. So you can always go for freezing. Second thing, deciding about the day of transfer, day 3, day 2. As I direct said, if you see good embryo, quality is good, then there is chance of getting that embryo converted into an blastocyst.
Yes.
So you can plan day 5. Irrespective of number of embryos. But on day 3, if I see that there is a lot of fragmentation and the embryo quality is not good, so one can assess it that it is not going to convert into a blastocyst. So then better to transfer on day 3 rather than waiting for day 5. And if you don't have that endometrium prepared on day 3, then better you freeze it. That is what is the in general.
Charu. Thank you, Dr. Patra.
Yes, that is what I was.
Yes. So
any patient is convinced about the
yes,
if you are poor,
that
you go
is
for 2 cycles.
That is what we again do when the number of I basically practice in Nova, so what we do is usually the blastocyst cycles. Majority are blastocyst cycles. If it is a non-viable cycle, we are upfront and we tell them. And then if the number of embryos are reduced, we counsel them. You have the options. First, you go for the transfer of these embryos. Second, you can go for another cycle of fresh pulling of the embryos. And third, you can choose if the first cycle, if your first option fails, you can choose your donor gametes. So there the patient has a clarity, and then they decide whatever they want. And after taking their proper counseling is done, and then we take it forward accordingly.
Thank you. End of this first session. Now I would call Dr. Suparnati to come and felicitate the national faculties and say a few words about the workshop and Isar.
I'm so happy to be here at Cradle Fertility, to be there for this workshop. On behalf of the organizing committee of Isar Bengal, my president, Dr. Sudeep Basu, my secretary, Dr. Suparna Banerjee, same namesake, and myself, I'd like a warm welcome to our national faculties who are here and the local ones. Hope you will have an enjoying session. The first 2 sessions were very nice and we had a good time. It is our endeavor on behalf of Isar Bengal to improve and of course make it more and more the academics and involve more and more people in this. And hopefully we are going in the right direction. Hopefully you'll be with us for the next 2 days, which is happening at Taj Bengal near City Center 2. So here itself, I'll take the opportunity to extend a warm welcome to all the national faculty and to take it forward from here. Thank you so much. My convenience here have done a wonderful job, Dr. S.M. Rahman, Dr. Parag Nandi, in conducting this workshop, and it's a huge pleasure to be here. Thank you so much. Thank you.
Dr. Suparna Banerjee will be felicitating the national Bhattacharya. I'm sorry, though two Suparna is there. They are all, associated with Isar, so we always get confused. Dr. Suparna Bhattacharya will be will be felicitating the national faculties. I would like to call upon stage Dr. Charudat Joshi, first speaker of the session. Have a photograph, please. Have an official photograph of this. Yeah. Thank you, Dr. Charudat Joshi. The next speaker, Dr. Falguni Patra from Odisha. Thank you, Dr. Falguni. Dr. G. Sumanna, please come up on stage. She will be delivering her talk in that second part of this workshop. She is from Bangalore. She is ex-faculty of AIMS Delhi. Dr. Amol, if he is here. Okay, Dr. Chidanand Das, please come on stage. He is from Bhubaneswar. Okay. Okay.
Next, we will be moving on to next session. I would like to call upon stage Dr. Falguni Patra to chair the next session. And I would like to call upon stage our speaker, Dr. Chid. Oh.
Jam pack session. After is a speaker, now I'm going to be the chairperson. I'm going to invite Dr. Chidanand Das, one of my good friends from Odisha, who is the senior embryologist, attached to IMS and SOM Hospital, Bhubaneswar, having a 14 years of experience, 16 papers reviewed and 5 popular articles. In achievement, he has got IFS Young Talk Award 2024 and Isar Rising Star Award 2024. Best Research Scholar in 2010, CSIR UGC NET qualified 2007, and his specialty is stem cell and development biology. And today he is going to deliver the talk on role of stem cells in ART, which is a very important, because nowadays we are all going to get a newspaper, Facebook, digital media, if through stem cell, this has created, from stem cell, this has created. So lots of things are going on stem cell. The upcoming field of ART, where the stem cell is going to take a beneficial role in ART, so lot of infertile couple will get the benefit. So I would like to invite Dr. Chidanand Das to come here. The stage is yours, sir, to deliver your talk. Thank you.
Thank you, Falguni sir. It's my immense pleasure to stand before you, respected members, Isar and organizing committee, and the dignitaries here, ladies and gentlemen, senior and juniors. Today, it's my passion to speak on stem cells because I have started PhD program on this subject. And after years of research, I am converted into an embryologist in a clinical research lab or IVF lab. And it is mostly I am working in a medical college under the deemed university Shikha Anusandhan Bhubaneswar. My contents will be rationale of the stem cells, definition and brief description, and its work in ART protocols, that is for endometrium where the embryo is getting implanted, and in ovary, as rightly the previous speaker has described about the conditions of ovary in different pathological conditions, and even though male factor is also expecting something from the stem cells and other aspects, and what are the practical realities, why it has not come to the clinic. So the very rationale is in ART, the IVF success rate, we are satisfied with 50%, and the other 50% is being not cared, or the research going when we think, we feel that we are going slow. If you will see the success rate, we are happy. And another aspect is poor ovarian response, that is higher FSH content in the circulating blood and lower estrogen content. And donor option in clinic, as it is a confidential issue to talk about the reproduction in a clinic, so they are compelled to agree for donor, as we are discussing with madam. And now, after that also, the take-home rate is low, even 50% from HCG rate, but the take-home baby is about 20 to 30% only. Definition: stem cells are pluripotent in nature, that is, they have self-renewal capacity, because every mitosis is going towards a differentiation through its chromosomal non-disjunction process, that is, it has a definitive number of cell divisions, but stem cells has no definitive division potential. As per its origin, it may be totipotent, or potential it is totipotent, pluripotent and multipotential, and as per origin it may be embryonic stem cells or adult stem cells. So in adult stem cells we can get from bone marrow, or every bone and its end has its potential to produce the hematopoietic and mesenchymal stem cells. Even the adipose cells have their potential. And next come another concept is stem cell products. Every cell has its own products or protein contents or some nucleic acids which are potential regulators of different metabolic and genetic pathways. And there are many concepts and approved in clinical trial that stem cells can be used for many degenerative diseases, which we will discuss in later on. So this is a stem cell. Any cell is produced, it has its own purpose, whether it will produce the same cell or any differentiated cells. So general clinical use is used the PRP, platelet rich plasma. It is often collected from your peripheral blood, where you have mass of MNCs, mononuclear cells, and platelet, which is essential to produce many protein factors that are essential to augment cellular potential in specific organs if it is present. So PRP is a concept As you may have come across in blood bank, they give PRP therapies for different clinical indications. Likewise, in ART, it has its own role because they are rich in platelets, that is, many of the growth factors. Another is bone marrow mesenchymal stem cells, adipose mesenchymal stem cells, and another is amniotic, and the new concept is induced pluripotent stem cells, that is, certain genes have been manipulated, which is still in experimental stage. Another is umbilical cord blood mesenchymal stem cells, where after birth of the baby, there is an option in gynae clinics that you can store your umbilical cord bloods. And another is menstrual stem cell is also there. In ART, we generally use PRP, platelet-rich plasma, mesenchymal stem cells, and other cells as mentioned. Another concept is the product of stem cells. This is a review article on stem cell therapy and an introduction to exosomes as a new tool in reproductive medicine. Although it is not a cell, it is a content of many factors essential to augment metabolic and to rectify or repair the injured organs. That is called exosomes. It is represented a bilayer of nanovesicles, and their membrane is prominently made up of ceramide, cholesterol, phosphoglyceride, and elongated free fatty acid chains. It contains even nucleic acids, proteins, enzymes, age-specific proteins for the target cell recognition and attachment, so that it can attach to the pathological condition of the body, that is from circulatory blood, it can attach to injured parts. So, as a content of materials, it has many roles. So, this is another paper, a narrative review of PRP in reproductive medicine, as it has role in thin endometrium and for poor ovarian response. This trend was also noted in women with recurrent implantation failure. That is, although the endometrial thickness is good, but there is failure in implantation. So we need to change the inflammatory molecule and augment some implantation molecule, activate the implantation molecules through the treatment of PRP or exosomes. As we all know, thin endometrium has the defined pathologies to some extent, that is Asherman syndrome, endometriosis, and infections, previous infections like TB. And RIF has no standard treatment to ensure pregnancy, and where only 50% positive results are being obtained after a homework of the clinician with the pathological symptoms like endometrial thickness, endometrial scar or scratching, and implantation activating molecules prescribed, and ongoing pregnancy as a risk pregnancy to be handled, and after to get the healthy baby. So this is a naturally sited endometrium. The endometrium is representing the number of stem cells in the basal layer, where the functional layer containing the specific cells in the whole menstrual cycle, where the post-ovulatory cycle contains enhanced by the progesterone hormone that is enhancing the implantation. PRP work to improve endometrial receptivity because it is the concentrated part of the whole blood. It contains about 10 to 15 times of more platelets. It improves cell proliferation, vascularization, anti-inflammatory properties, reduction in the degree of fibrosis, which is a general phenomenon inside the uterus, with the help of concentrated peptides, growth factors, and cytokines in the PRP. Can you switch up the light? So this is the array of molecules inside the uterine environment or the endometrial thickness, how it enhances. It is being observed by ultrasound. Now the ultrasound technique is also describing the vascularity, and the vascular enhancement is due to the stem cell potential and how it augments different molecules into that place. And PRP only helps to concentrate these molecules. So those molecules may be PMNs, antimicrobial peptides, adhesion molecules, growth factors, metalloproteinases and fibrosis factors with different kind of cells of different functions. So more opportunities we can explore, pooling the subject by multicentric studies, because every clinic or every IVF center is busy with the upcoming patients. To concentrate on a single patient and to give more time to it, we need to discuss with multiple faculties. Enhancing platelet production with some supplement prior so that platelet quantity can be enhanced, and quantifying platelets so that there are some cases we get benefits and some cases with advice we are not getting any role on the PRP. In that way, we need to analyze why we are not getting. And uterine and endometrial optimization with other clinical and endocrine factors. And we should know the uterus and platelet product interaction as I have showed in the last picture. Platelet types and their role in endometrial surface, and why we cannot use the platelet concentrate as in the available in the blood bank. So there should be the receptive endometrium, as in the post-ovulatory phase we prepare the endometrium. It contains the materials for cell proliferation, cell migration, tissue growth and healing, neoangiogenesis, that is making of new blood vessels, chemotaxis and immune response. And there are some factors which has anti-inflammatory properties. So it is not only helping in the implantation, but it can regain different organ functions like ovary. So practically the PRP has platelets above baseline. They are 2 to 4 micron diameters, and it is not a complete cell. The cell do not contain any nucleus. Each microliter of blood has 1.5 to 3 lakhs of platelets. They have chromomere and hyalomere. They have actin, myosin and thrombostenin. It is often required in physiology, the plugging the injured part. And it also contains fragments of subcellular organ like endoplasmic reticulum and Golgi. Those are rich in enzyme, calcium, mitochondria, and the system of enzymes. Prostaglandins that act on endothelial cells for local inflammatory actions. They only attach to injured cells with rich in phospholipid and membrane that help in activation, where the half-life is 8 to 12 days. In general, they come in contact with damaged endothelial cells. Their contractile proteins contract forcibly to release several protein factors and become sticky to protect the inner organs. So these specific factors are fibronectin and vitronectin, growth factors, prostaglandin, growth factors, epidermal growth factor, transforming growth factor, basothelial, endothelial growth factor, and basic fibroblast growth factor. Among cytokines, there are set of interleukins are being secreted by the concentrated platelets, or some people they dip into, after getting the platelet concentrate, they dip into liquid nitrogen so that the cells will burst to release more growth factor. So this is another reference only. I am telling the protocol that after taking the whole blood, you centrifuge first time with 1000 RPM, then take the supernatant, then again centrifuge about 2500 RPM, and then get the best fraction and use them as an injection after calculating the total platelet content. And then you can repeat it for 2 to 3 times, or else another method is that you can dip into liquid nitrogen and then inject it into your cells. The first is you have to quantify how much platelets have been injected. If any other protein assay can be done also, it is better that you can send to different chemistry lab so that you can know the protein content of it, or any chromatography method can help to qualitatively analyze the total number of growth factors and quantity growth factors, and the purpose is being solved as per the pathology in the endometrium or in the ovary. The PRP cannot be given where there is coagulation disorders or cancer or having active infections anywhere else. Another aspect is, as Falguni sir has described, that there are 2 ovaries, but we are getting less than 3 oocytes where the IVFs cannot work. Before that, if we can counsel the patient that your platelets should reach your ovary, or the factors augmenting the stem cell potential, or directly stem cell we can inject to the ovaries. As in Odisha, he has done with his team in Sujata Kar clinic, and it's a long-term study also, because after 1 year only you can get the ovary is rejuvenated to produce the AFC count.
That was done by both, the freezing was done by carousel and the thawing was done by ovarian tissue, so we have did both.
Thank you. So this is a complex disease affecting quality of life as described. Ovarian function is hampered. So there the patient is totally frustrated, and there is no way in clinicians to handle the situation. And they suffer of hypoestrogenism, hypergonadotrophism, primary or secondary amenorrhea, and finally the infertility. And other morbidities are added to the POF, because the ovary is not only causing the infertility, but there are certain physiological issues are there, like cardiovascular disease and many immune disorders. And there mostly palliative treatment is there. So there is a option of only donor finding the option. So here the PRP can find. This is a study in 2020, effect of intra-ovarian injection of autologous PRP on ovarian reserve and IVF outcome parameters in women with primary ovarian insufficiency. There it shows more than 20% patients got a healthy baby born. So there are clinical trials going on around the research institutes or the clinics around who are dealing with, who have facility of stem cells. This is showed by Falguni sir.
Sir, we are running of time, so we have to make it a little faster.
So as like that, these factors are acting on different signaling system to activate the ovary. So they act on the folliculogenesis, estrous cycle, hormone levels, oocyte quality, and fertility potential has been increased after injection of stem cells and PRP. They have been calculated by the FSH level lowered, rate of mens of the patients, and ovarian blood flow has been enhanced, and finally the pregnancy. So a stem cell basic is not so much difference than IVF lab. It is rather less complicated. and they need a basic animal cell culture facility with validated equipments and skilled biologist with an assistant so that the quality control can be maintained. And government has a guideline on how to do a stem cell laboratory and how to quantify or qualify different cells that are counted as stem cells. They are represented by a specialized laboratory with a laminar flow, centrifuge, and to quantify the flow cytometry with CD4 counts or the growth factor, different cell surface antigen markers. So next is the limitations. Those who working in IVF lab, there is no limitation. We need willpower to add on the facility for PRP. Many centers in India are working on this, so I am not going into it. So challenges we can do well as we go for the guidelines of ICMR or Department of Biotechnology. I have visited, and there is some work going on adipose derived stem cells. They have taken plenty of adipose cells and centrifuged to concentrate and used in a Chennai based hospital. They are working for the gastroenterologist patients. There is a clinical trial file room so that we can take many things. Next is male infertility. We can also inject PRP in testicular cells, but it is still in very low success rate things. There is no clinical trial on the male infertility cases. Instead, there are other cases in gynecology, the use of stem cells. And these are few of my publications. We have worked, before coming to IVF sector, I have worked in orthopedics and neurology. So there are some few cases, and we have isolated that primordial germ cell, how germ cells move. So now there are publications that bone marrow stem cells can able to produce even gametes. So still we feel it's in fiction, but it has realized in perhaps developed country labs. So stem cell have huge applications in ART. More studies could standardize specific protocols. So I invite all the big Bs to invest and to be more involved in the subject. Multicentric studies can give confidence to us to give options to POF and thin endometrium and RIF cases. The laboratories are very less, and clinical trials are getting synchronized with the help of government policies, so that along with other diseases it can be addressed. This I thank to my team members and who gave me the option. Thank you.
Thank you, Dr. Das, for briefing the entire thing, how the stem cell is going to take care in the ART part, that you have told of the thin endometrial preparation that is going on, ovarian that is going on, and in the male things that also it has started that you have told, and what are the future research can be done with all the studies and all with a good future. Thanks for the very simple and very clear discussion on this. If you have any question from the audience or something, that will be, we will carry on, or as the time is going out, we'll move to our next session. Thank you.
Thank you, Dr. Chidananda Das, for delivering his lecture. We would now running short of time, so that's why I would like to call up on stage Dr. S.M. Rahman to felicitate the national faculties, and then we'll be going to the next session. So please, Dr. Rahman, to felicitate. Yes, first of all, I would like to call upon stage Dr. Charudat Joshi. Uh, yes. Thank you. Thank you. Dr. Falguni Patro. তোমরা চলে যাও। Yes. Yes. The next speaker, Dr. Yes, Chidanand Dash. Please come up on stage. He is from Bhubaneswar. Next, Dr. Rakesh Shamal. Then Dr. Pratushita, please come forward. Rakesh Shamal, yes. He is from Kashmir. Dr. Pratushita, please come up on stage. She is a freelancer and she is based in Bhubaneswar. Thank you. Then we'll be concluding this particular session. The next session will be starting now, and the clinical part will be started, and then the felicitation will happen. Okay.
Next, we will be moving to our next session. I will like to call upon stage our next chairperson, Dr. Charudat Joshi on stage.
Yes. হ্যাঁ তোমার লগ আউট হয়নি ফরচুনেটলি ও লগ আউট করেছে ওখান থেকে বলছি কথা হয়েছে আমার ও লগ আউট মোবাইল থেকে করে দিলে হয়ে যায় ও করতে পারেনি ঠিক করে করেছে লগ আউট না জায়গা করা আছে কটা দেবে 12টা 12:30 দাও এমন আপনি কেটে সাড়ে 12টা
আমি জেনারেট ইয়ে করছি আর টাইম ইয়ে করছি না মেনশন করছি না ওনাকে টাইম মেনশন করে দেবো 12:30 এটা হোয়াটসঅ্যাপে করে নিতে পারবো কাকে দেবো
এটা পরাগ দাকে এটা আর এটা পরাগ গুগল মিট পাঠিয়ে দিয়েছি তোমাকে দিয়ে দিয়েছি লিংক দিয়ে দিয়েছি একটা জুমে করে নাও জুমে সারা বলতে আর বলে নিয়েছি
বলছি জুমে অন্য কারোর একটা মেল আইডি দেবাংশী দত্ত বলে কারোর মেল আইডি লগ ইন আছে এটা থেকেই করে দেবো আই ডোন্ট নো
লোগো গেলে বেটার না
ফার্স্টে 3টে তো
জুমে একটা থেকে করো একটা 1:30 থেকে করো ঠিক আছে
দুটো
পরে আমরা লিঙ্কগুলো ল্যাবে ঢুকতে হবে তারপরে আমি ল্যাব সেশন করতে পারবো সেটাই হয়ে যাবে তো ওই লিঙ্কই হয়ে যাবে মেনশন করা নেই
রণদা আমার ফোনটা একটু ছোড়ো না আমার ফোনটা না হ্যাঁ আচ্ছা 1টা থেকে 1:30
একটা থেকে 1:30 একটা 1:30 থেকে
ইভেন্টের নামগুলো কি দেবো মানে কোনো ইয়ে আছে
ডক্টর লীনা মালক
একটু
এক মিনিট
পাশেই হবে তো? একটা থেকে দেড়টা পরে করো, আমি এখন কিছু টাইম দিতে পারছি না, একটু দাঁড়াও, পরে একটু পরে করো। আমি এটা কত নম্বর সেশন? রাকেশ শর্মা, চিদানন্দ দাস হয়ে গেছে।
Okay, so it's my privilege to invite our next speaker, Dr. Rakesh Samal. He is Director and Senior Embryologist attached to Imprimis IVF and Fertility, having experience more than 15 years, various international and national publications, achievements, member of Isar IFS ACE, QAI Assessor, IFS Achiever Award, Isar Embryology Excellence Award, and the specialties embryology and genetics. So, over to you, Dr. Rakesh, to deliver the talk.
Thank you, sir. Good afternoon, everyone. So my topic is today's embryo biopsy and PGT, unlocking the genetic secret of life. So all we know that why we are doing PGT, PGTA, PGTM, PGTSR. So for this thing, we need to do the embryo biopsy. So embryo biopsy is a procedure that involves the removal of one or more cell from an embryo for genetic analysis, typically performed during in vitro fertilization to assess the embryo genetic health. So these days, those recurrent failures more than 35, 37 age, advanced age, recurrent aversion. So for them, we are used to do the PGTA, the aneuploidy test and all. So this is the procedure where we we did means zona drilling and then the part embryo biopsy to take the cell more than 1 to 2 cell. So purpose of PGT is that to identify genetic abnormality in embryos before implantation, thereby increasing the chances of successful pregnancy and reducing the risk of genetic disorders. As I said that for the patient, those are advanced age and recurrent failures, if there is some earlier genetic abnormality, so we should to check before the transfer. So this is the purpose of PGT. So embryo biopsy process. Handling and culturing embryos, proper handling protocols are crucial. Embryo must be cultured in controlled environment with specific temperature, pH, osmolarity to ensure the health and development. So when we start for the embryo biopsy, so we need to do the checklist. Your micromanipulator is properly validated. Your ICSI, your biopsy dish should to prepare 1 hour before for the biopsy, and your PVP and your MOPS or HIPS buffer you can take because you are doing outside the. So you to maintain the pH and osmolarity, the buffer MOPS or HIPS maintain the osmolarity and pH. So and by embryo biopsy should to be do very in aseptic condition. So before to that, so which laser you are using, your micromanipulator, your disposables, everything should to be checked. So at the time of biopsy, it's not to happen. And the laser, which laser in your lab, that should to be validated properly. So then your target, the laser shot, when you giving the laser shot, the target should to be aligned properly. It should not here and there. And then after your micromanipulator, the pressure should to be very low, and the laser micrometer should to be 300 to 350 micrometer. So the zona should to not more open. Then tools and equipment used. The biopsy process typically requires micromanipulators, lasers, or precision removal of specialized media to maintain embryo viability post-procedure. Same as I said, because these days many lasers are there. Saturn is there, your Hamilton is there, Octase is there. So, and these days lasers are coming with so much advance, so you no need to be move the embryos. You can move the laser shot anywhere. So you can do the biopsy where you want to place the embryo and do the zona drilling. So, and you should to know that embryo should, it is working. Video is not running. Sorry, the video is not running. But when you place the embryo in the XC micromanipulator, you should, your holding part, you should to take care that your inner cell mass should not to be disturbed. So the inner cell mass should to be placed at 10 o'clock or 8 o'clock, so that by through holding pipette, it should not to get more pressure. So you should to hold your inner cell mass at 10 o'clock or 8 o'clock, and then you take the laser to the zona and give one shot, two shot, and the inner cell lining should to detach from the zona. So then you can easily aspirate the trophectoderm. So when you are little aspirate the trophectoderm, you can do little one shot laser, then you can do the flick method. The laser, it's not working, so otherwise I can show you how to do this. Otherwise I can show you in the lab. And then do with the PBS media 3 times, rinse the biopsy cell and put it in the microcentrifuge tube, which is ready to use with coming the 2 microliter of PBS media. So safety and ethical consideration impact on embryo viability. The procedure itself can pose risk to embryos, potentially leading to lower implantation rates. Careful techniques is essential to minimize the damage and ensure successful. Yeah, that is the require the expertise and the how much you are experienced, how much you are delicately handling the embryo, because it's very chances of damage is more if you will not properly handling the embryos at the time of biopsy. If you will, aspiration is getting more, so more number of cells will come, then embryo will be get degenerated, embryo will get not recover. So your procedure should to be very delicately, minutely handling the embryo. That's everything you should to take care. And ethical dilemma and regulatory guidelines. Ethical concerns arise regarding the manipulation of embryo, necessitating adherence to strict regulatory frameworks to balance scientific advancement and moral implication of such procedure. This is also so because when you do embryo biopsy for a patient, you need to the patient history, why you are doing a patient biopsy, and you need to ask patient counseling, genetic counseling, and with counseling the patient after the biopsy, after the your genetic report, whether it is coming is all embryo is coming is aneuploidy. So what will you do the next procedure? Because a lot of money is spending the patient. And if mosaic embryo is also coming, so if mosaics are more less than 40%, 50%, the embryo can be transferred or not. So everything you should to elaborate the patient, and after genetic counseling with the patient, then you should go for the transfer or not to the transfer. So these ethical things should to be checked properly. So for what we are doing on the PGTA, types of PGT, PGT for monogenetic disorder, PGTM, so designed to identify specific genetic mutation that can lead to inherited disease, allowing for selection of embryos free from these conditions like cystic fibrosis, sickle cell anemia. these embryos should be go for diagnostic procedure for PGT-M. PGT for chromosomal number PGT-A, chromosomal abnormality, screens embryo for aneuploidy, which are imbalance in chromosome number helping to improve implantation rates and reduce miscarriage risk. So this is most commonly we are doing the PGT-A for the good and healthy embryo, healthy genetically embryo. So if embryo is aneuploidy, so you should not to go for the transfer. So euploid embryos, one embryo can transfer. So successful implantation and pregnancy can be also occur. And PGT for structural rearrangement, PGT-SR focuses on discovering chromosomal structural rearrangement such as translocation, inversion, which may lead to reproductive issues of genetic disorder offspring. Accuracy and reliability. Technological advance. Recent advances, sequencing and molecular techniques have significantly increased the accuracy for PGT, enhancing detection rates and providing more robust genetic information. These days, earlier, a whole chromosome can't be detected. So because these days, next generation sequencing is working, so whole chromosome can be detected and more advancement has done with the genetic analysis. Limitation and false positive and negatives. While PGT is highly precise, it is not infallible, plus false positive and negative can occur, leading to potential ethical dilemma and emotional challenges for prospective parents. Same as I said earlier, that patients should to counsel properly that after PGT, if there is no embryo, how to handle, what can be do the next procedure, everything. So you should to check, counsel the patient. That is a very important part. So clinical application and outcomes preventing genetic disorder. Common genetic disorders screened genetic screening often focus on disorder like cystic fibrocell, sickle cell anemia, and tests such as disease allowing for early diagnosis and informed reproductive choice. The PGT-M were filed before elaborate. And case studies, success rates, case study illustrate successful outcomes where screening led to healthier pregnancy and births, significantly reducing the incidence of genetic disorder in newborns. Here, I also have published 2 papers that mosaic embryos we have, because a patient has got three embryos, all 2 aneuploidy and 1 mosaic embryos. So that embryo geneticist has told that this is less than 40%. So here there is no chance to embryo for the patient to transfer. So that 40% mosaic embryo transferred with checking with NIPT and all. So the patient results delivered healthy babies. So this kind of studies can help you in to do whether we go for transfer or not. So all these things. So is PGT right for me? The following couples or individuals can benefit from pre-implanted genetic testing. Individuals or couples with known genetic condition or a family history of a genetic condition, like as I said, women over 35 or those with ovulation difficulties, couples with previous recurrent miscarriages, couples with previous unsuccessful infertility treatment, couples with an unexplained diagnosis also. So these days is required the PGT patient if they are. So here are some consideration when deciding whether or not to pursue pre-implantation genetic testing. As with many tests, PGT may be not 100% accurate as it is considered a screening test, not a diagnostic test. There is still a chance of implanting of an embryo with disorder. So, because when patient come to you after the genetic testing and all, patient asks, feel that pregnancy can be occurred 100%. But we should to counsel him that after 100% accuracy with euploid embryo, that can be also sometimes not maybe give the implantation. A pregnant woman who underwent PGT because she was considered at risk of a flawed embryo should still have a parental genetic testing done, because we are doing the screening only. We can't do any diagnosis procedure for patients, so it can be inherent to the baby also sometimes. The biopsy, handling, freezing, and thawing result in damage to about 5% of embryos, causing implantation failure. This is because of that the expertise, the handling your embryos and your doing freezing and thawing again. So a lot of procedures have need to require for embryo biopsy. So that expertise, that technicality, you should to be maintained very minutely, and you should to be very confident when you're doing the procedure. Otherwise, the 5% is mentioned because of that. If you can't handle properly, the chance of implantation 5%. What pre-implantation genetic testing is not. Pre-implantation genetic testing is not a way to make a designer babies. It doesn't involve manipulating or altering an embryo's genome. It is not a tool that simply detects genetic variation that the embryos has. So, because you can't change any genetic chromosomal of the babies. What it is, their parents, it is only their gene only can occur. It is also not a way to genetically select for a child with higher intelligence like athletic ability, height, or the other similar traits that are affected multiple genes. The number and types of genetic variation that the tool can detect are limited. Another limitation is that our understanding of the genes and variation that underlie these traits is incomplete. Not only are traits like intelligence and athletic ability genetically complex, they are also influenced by the environment. So, because these days sometimes non-medical patient and other ask whether gene can be modified or mutated or means something to for healthy babies, they are asking. So, it should be also, they should be counsel. Thank you.
Thank you, Rakesh. Do we have any queries or any questions for Dr. Rakesh?
Rakesh, just two questions. One is, how many biopsies do you think an embryologist should do to attain some expertise?
For training purpose, you are asking, or
gradually as one trains?
Look, means if an embryologist want to train, then she should to get means verify by the senior embryologist how he handling the gametes, how he handling the manipulators. What the means if though 2 times, 3 times means he need to check. Then only verified by the others he can go for training for day 5 embryo, 4, 5 embryos, and for day 3, because these are day 3 embryos not doing biopsy because a lot of mosaics are coming. So day 5 embryos are surplus embryo then lab. So he can practice after getting consent from patient or some institute.
So usually how long does the learning curve take?
This is depend upon the calibrity, how you take it. So means as often easily or because I have seen, I have trained 3, 4 embryologists. One is doing good, but another 2 is not can do better that way. So I can not validate them because you are dealing with embryos. Lot of emotions, lot of things are there.
Okay. So second question is, we've seen embryologists follow 2 types of techniques. So one is give the laser in the morning, wait for the embryo to hatch and then do the biopsy. And some of the others do laser and then same just time. Do at the same time. So what is advisable?
I prepared at the same time. But some embryologists are giving, because if in the expansion is not over there, if it is embryo 2A, 3A, that time you can give the laser and that can expand to 4A, 5A, so that it can be automatically herinate. But what happens sometimes, its herination can occur with the inner cell mass.
Correct.
So that time, but you should not to disturb the inner cell mass. So that's why I prefer always same time to give the shot and do flicking method. Okay. Some people are give laser 4, 5 times to and pull it lot. So that can be also sometimes damage can also occur. So that things where you get more expert in to do in flicking method, sorry, or else your aspirating means laser, but you should not give also more laser. That can be also adverse effect to the embryos, degenerate the embryos. So after embryo biopsy, you should culture for 1 hour. The embryo should to be expansion, get recover properly, then you should go for freezing.
Okay, thank you.
Thank
you. We will first assisted hatching we will do in the morning. Then after getting out the hernation, we will.
Yeah, assisted. Some people are giving on day 3 also. Okay, some people's giving the sort, means for zona opening.
Thinning.
Not thinning. You need to give sort, the zona open. Means not thinning. Thinning can be not help you. The sort, the laser sort. You should to give the laser sort in the day 3 or in the day 5 early in the morning.
To the zona only.
Yeah, at the zona, you should give one place or two place. So then if embryo get expand properly, so herination can be occur. But this is the point where I said what I said. The herination can be occur with the at the place of inner cell mass. So that can be issues with. Then again same you should to be about the herination part and about you holding the embryos at inner cell mass at 8 o'clock or 10 o'clock, so that because our motive should to be, because inner cell mass is giving all your body part, organ, everything, so that part should to be not to be means affect.
Okay, thank you.
Thank you.
So thank you, Rakesh. I just want to say about your question, what you're saying, being an embryologist. See, what I feel is that even after spending so many years, I still feel that there is something lacking and I need to improve. So as far as learning curve is concerned, I think it is more of expertise and more of experience coming, and that comes by performing cases day by day. So initially they should start with not more than one case in a day. Maybe when they are confident, 2 cases, 3 cases, like that. And that is what is the advantage of having an in-house person, because you can always manage the time. If he has to come or I have to come, I will say, no madam, we have to keep 5 cases in a day, and at that time only I have to do. So that is the difference. Okay, so thank you very much, and we are moving ahead with our next, it's an online lecture, I suppose, right?
Next is an online session from AIMS Delhi. So I would like to call upon stage next chairperson, Dr. Chidananda Dash. Please come up on stage.
So if you have any question or if you want to discuss anything, you can please discuss. Otherwise, in 5 minutes, we are starting that next lecture online.
Young minds should have questions. Young minds should have questions.
Yeah, that is what I am expecting. Because what I was telling to you, I visit so many now universities offering this MSc clinical embryology courses. What happened that this young generation which is coming, they just feel that performing XC is that's all. That is, I am a perfect embryologist, which I feel needs to be rectified, because as an embryologist, there is so many things has to be done by an embryologist. They have to perform so many activities, and now as embryology and embryologist is a recognized field, so now they are more responsible. Initially, for example, if you are the head of the center, you are a clinician, whatever goes wrong, it is your job, you take care of it. But now I am also equally responsible if something is not happening in proper way. So I think it's a learning curve, never ends. It is always learning. Every day you come to know about something new and you want to incorporate. And this goes in this way only. क्या बोलते हो आप?
No,
It's not 30, 40. Even you do 50 biopsies. With every biopsy, you will be more confident. Means what I can understand is, right now you cannot offer them to perform biopsy independently. But after doing 4-5 cases, you can give them some 2 or 3 embryos to perform biopsy. Later on, you can give the complete one case for performing biopsy, and that's how you have to. Because the practical problem is we don't have that practical modality in India available, right, that we can give hands-on training kind of thing on the human embryo. That we cannot. We can offer it on animal embryos, animal model. And that is also at very restricted places they are doing. So we have to, means, unfortunately it's a trial and error kind of thing. Waste embryos, you can just keep on trying laser hatching and then try to take biopsy out of it and then see what happens. But taking biopsy is not a problem. Picking that biopsied material and putting tubing is very important and crucial. All tactics and everything has to be applied at that place.
thank you. Actually, madam has rightly told. I could remind the ICSI time in 2013. Madam has given after the training the whole case. I have done very well all ICSI. The next day, no fertilization. So this is the experience. Now also my clinician is asking, I have taken a training on biopsy, everything. And I have seen 7 to 10 things. I have taken trial run with VGT, whether you will do or we will call someone. So as the sample is so precious and it is not so available. So can I know my listeners? Your name please? Yes, where from? What do you want to do?
Hello everyone. Embryologist.
That learning curve never ends, it is always learning. For me, being an embryologist, the most important character should be there in an embryologist is passion about the work and patience. Because in embryology, you cannot do anything in hurry. You have to plan, you have to meticulously plan, and you have to perform it in a systematic way.
Yes.
So, for me, suppose someone comes, in 5 minutes I inject 10, 15 oocytes. It's not a credit to that, because every oocyte, it takes some time, orientation, you have to take some time for. So, having patience in performing, how you are sitting, that also matters in experiments. This recently I have come across one paper. They have studied that how an embryologist is sitting on chair and performing ICSI and the outcome. And they found it that if the sitting is not proper, the outcome fertilization percentage compromise. So we never realize this, that I am just comfortable that I have injected, but how it is injected and how comfortable I am. So there are so many things to be learned.
Sir, I have a doubt, sir. I'm Statisha, working as a senior embryologist in Chennai Fertility Center branch in Salt Lake. Sir, what should be taken care during oocyte freezing, sir, to avoid degeneration?
See, very important thing in any freezing aspect, as far my observation is concerned, it is the protocol and timing you follow. Whatever timings are given, it depends on protocol to protocol. You cannot just treat all protocols in same way, all media in same way. There are different medias available in the market for freezing. So for me, following that protocol, following the temperature what is prescribed, because mostly degeneration happens just because the time of transferring from one media to another media is not properly followed. Otherwise, a good mature oocyte should survive. And I have seen, I do myself, I almost have more than 95% survival, hardly any mature oocyte degenerate. The problem is you have to give that much of time. Like many people ask me, 10 minutes, if it is 10 minutes and 1 second, then what will happen? Nothing is going to happen in embryo because you have to see the expansion after contraction, right? If expansion takes, it may be possible for some embryos it is 30 seconds less, or for some embryo it is more 30 seconds, more than 10 minutes. So you have to see the proper expansion. If it is there, you just go ahead. But then you have to follow some particular protocol. Then only you can reduce. And initially, oocyte is more fragile than embryo. That you have to remember. And that's why the degeneration in oocyte is slightly higher. But then if you follow it properly and you do systematically, I don't think there should be any problem. It should survive. How you are storing media, what amount of media you are taking, that all matters. Madam is online.
Hello. Hello, ma'am. हेलो मैम. मैम आपको अनम्यूट करना पड़ेगा. ऑडियो कहाँ पे प्रॉब्लम हो रहा है? Hello, ma'am.
Hi, Rahman. Can you hear me?
Yeah, ma'am. Yeah, ma'am. Now we can.
Okay. Am I audible?
Yes, ma'am. You are very much audible.
So I can go to present and put the select my.
Yes, ma'am. Yes, ma'am.
This is Google Meet, right? So in Google Meet, how do you go and attach your slides? I'm not very savvy on Google Meet. Parag.
Parag ma'am lab में है. Parag is inside lab, ma'am.
मुझे बता present इसमें present now है ना? Sorry, apologies. It's present now. When I go to present now, I don't see my this thing. Desktop come because it's all open on the desktop. Share.
No. Ma'am presentation की करे share करो.
What is the share more options? A full screen report. So here I am going on to the present now, right? Present now, okay?
Yes, ma'am.
Present now में मेरा content नहीं आ रहा है. It's choose to share with the Meet Google. From no, this is not showing my desktop options.
मैम आपको फाइल ओपन करना पड़ेगा.
नहीं मेरा फाइल ओपन है, but where do I go on the icons? There is camera, there is present now, there is report use full screen.
Present now पे जाना पड़ेगा शायद आपको.
Present now पे जा रही हूँ. I'm opening present now, but on the present now I am not going to understand where to get my windows,
Go to
right?
window. Yes, ma'am.
Yeah, I've opened the window, but on the window I can't see my desktop page come. Then entire screen पे जाती हूँ तो no, it doesn't show my entire screen also. How do you share? किसी से पूछेगा? Was my Rotas. किसी को पढ़ के लाना गायनी ऑफिस से. Just let me ask them. They do. No. Give me just 2 minutes. So maybe I can open that as a window and then say entire screen. That's what I will do.
Yes, ma'am.
Okay. Can you see something?
Yes,
ma'am.
Yes.
But then you know what is happening? It is not in a full mode. Is it in a full mode? Sapna, can you help me? क्या दिख क्या रहा है उसमें? What are you seeing? Is my presentation come?
Enter screen.
Ma'am,
Has my presentation there?
we can see your entire screen, but not the presentation.
Not the presentation. It says stop presenting. I'll stop presenting. And Sapna, Google Meet पे present now. Select to share. मेरे को ये PPT present करना है. ये वाला.
Options present now
Share नहीं हो रहा है. It's not getting shared. Zoom option is easier to upload. So I don't know.
Okay. So, ma'am, go for Zoom, ma'am.
But Zoom is not opening. When I'm going in Zoom, your Zoom is not allowing me in. Share entire screen. Share from the window. Okay. Can you say this? Can you see it now? Can you see now?
Yeah, right. Yes, ma'am. Yes, ma'am.
Okay.
Now we can see the presentation.
Thing is, you can see. But the thing is, इसको मुझे ऑप्शन में जाना पड़ेगा as ये full slideshow में नहीं आया है ना? अब has it come in full slideshow? Has it come now? Has it come now? अभी पूरा full slideshow में है?
No, ma'am.
It's showing from me. It's my side showing.
Okay, ma'am. You start presenting then.
No. उसमें screen आ रहा है मेरा PPT का.
आपका screen हमें PPT का screen हमें दिख रहा है, ma'am.
दिख रहा है ना?
हाँ, ma'am.
पूरा दिख रहा है, full on दिख रहा है.
Yes, ma'am.
No, can you see my PPT?
Yes, ma'am. We can see your PPT. Yes, ma'am.
Ovarian cryopreservation procedure. This is my first slide.
We can see the slide cancer statistics in India. Third slide.
No. That is not my presentation. Move करता हुआ नहीं दिख रहा.
No, ma'am.
Move करता हुआ नहीं है. Then it is not. That is.
Ma'am, keep it.
No. अभी देखो. अभी मैंने stop sharing करा है.
हाँ, stop हो गया.
अब मैं दोबारा करती हूँ. I will enter now again. And I will present now from the window. OTC share. Can you see it now?
Yeah.
First slide.
Yes, ma'am. We can see the first slide.
You can see it. Okay. Is it the first slide?
Yes, ma'am.
Can you see me moving? Move करता हुआ दिख रहा है?
No, ma'am.
No.
It's not moving.
You have to go to the presentation, not from Google Meet, right?
I'm going to my presentation. मैं presentation पे ही जा रही हूँ. I'm going to my presentation now. I'm moving it. मेरे यहाँ पे move करता है, आपके यहाँ पे move कर रहा है?
नहीं, मैम.
मैंने full screen कर रखा अपने screen में. Again, I will stop sharing. Can I go on the go? This is. What are you people seeing? I think there is always a problem with See, I'm sharing it. I'm putting my OTC presentation. I put the word share. So, ये full screen नहीं आता ना? ये full screen नहीं आता.
No.
क्या move? But then I have to come to my PPT to start moving it, ना? अब move करता है? Does it move now?
हाँ.
Yes, ma'am.
So you know what happens? जैसे मैं full screen डालती हूँ, it stops sharing. Let me try again. Now it's full screen.
ऐसे ही करेंगे.
Full screen है.
Yes, ma'am. आप शुरू कर दीजिए presentation.
अब move कर रहा है. Is it moving?
Move कर रहा था अभी तो.
अभी कर रहा है. Okay. Can you see me moving now?
Yes, ma'am.
Okay, thank you so much. So good afternoon, everybody. I think it's a first congratulations to Dr. Rehman, Dr. Farag for holding this brilliant workshop on the Isar platform. And I think I am missing it. I had loved to come to this conference on physically, but I think we have a conference, so we are busy. Anyway, I will start the topic because we missed a couple of minutes in setting. So I've been asked and requested to speak on a topic called ovarian tissue cryopreservation. What is the procedure? What are the challenges? And what are our future directions? Certainly, it's a very exciting topic because not very many people in the country are doing ovarian tissue cryopreservation. And I would just take you what is the history behind it, how it's developed, and how at Ames we are established this procedure. So I always like this, the wordings of Albert Einstein. We are insane. We are insane people, and I think Parag and Rahman will believe it. We keep on doing the same things, but why are we repeating it? Because we were expecting a different result. Obviously, the result has to be better than the previous one. So I will just begin by saying that cancer is on the rise world over, and so it is in India. And I don't want to bore you with statistics. We realize that when cancer hits a young girl, the family initially forgets and is worried about her safety and her life. But once she survives, next comes the quality of life. And in that, we know that all drugs, chemotherapy or radiotherapy, will kill her gonads, or the man's sperms will go. But then, when they survive, the issue is what can we become a mother? What I can father a child? And therefore, fertility preservation becomes a very important issue for IVF specialists and also for embryologists. Now, some common cancers which we are seeing in our country are these, which are affecting women who are in the reproductive age groups, and we are seeing a rise. So the challenge for us is a balance between, first, should we save their life, or should we be able to do the fertility preservation? Because at that sensitive issue, it becomes very difficult to discuss these issues. And I will tell you how it is important.
मैम your slides are not moving मैम और एक बार देखेंगे अभी मूव कर रहा था फिर बंद हो गया
अभी मेरे पास मूव कर रहा है
बट हम लोगों को दिख नहीं रहा है आई थिंक वो फर्स्ट स्लाइड में
क्या दिख रहा है तुम लोगों को
बीच में आपका स्लाइड तो मूव करने लगा
can I send you my slides and you people move
yes ma'am that's better आप भेज दीजिए
अभी
मूव हो रहा है मैम अभी मूव हुआ है मैम
ऐसे करती हूँ बिना स्लाइड शो बिकॉज ना मेरे वीडियोस हैं वो तुमको भेजने से फायदा नहीं होगा आई थिंक
बिना स्लाइड अभी दिख रहा है मैम हाँ ऐसे ही रहने दीजिए मैम यस मैम
so therefore I think it becomes a very sensitive issue for any family to talk about first saving her life or talk about fertility center, and I will just take you later in the slides how you handle and tackle this important situation. So whenever we get a woman or a young girl or a prepubertal girl for whom we are trying to do an ovarian tissue graft preservation, we have to justify ourselves. What is the realistic chance of that individual surviving? If the 5-year survival is more than 50, however, in our setup, we say at least 75 to 80%, only then will we go ahead. We'll be stupid if we tell a patient who has a 5-year survival chance of just 20 to 30% to cryopreserve or go in for fertility preservation. Now, we also know that when they are subjected to chemo or radiotherapy, there will be premature ovarian insufficiency and there will be gonadotoxic effect. Therefore, it is very important to understand that if we are offering these services, we are better to do them when they are younger than 35 years. I don't want to tell you, there are beautiful guidelines from ASCO, even the SRM, that they say that fertility preservation is a must. Now, whenever we do fertility preservation, the strategies are right from preserving embryos, oocytes, or ovarian tissue. They all will depend on what is the age of the girl, whether it's an emergency situation, what is the type of chemotherapy or radiotherapy she gets, how much time do we have at hand? Because if we're trying to create embryos or cryopreserve her oocytes, we definitely need a window of at least 2 weeks in hand at whatever pace you are or whatever protocol you use. And also if she's married or she's single, because if she's single, then we are better off doing an oocyte cryopreservation as against. But since I'm not showing the slide view, I would rather say that I will go straight to ovarian tissue cryopreservation. Now, when do we do ovarian tissue cryopreservation and when do we do embryo or oocyte? Certainly a female who has maturity of the ovaries is good to go for an oocyte or embryo cryopreservation. But young girls where the HPO axis is not so active, where we know that there is yet the response of this ovary to stimulation by gonadotrophins, and these ovaries are naive, they are still innocent, they will not respond, we should go in for ovarian tissue cryopreservation. So therefore, these are girls who are prepubertal, because we know they're less than 13 or 15 years, their ovaries may not respond. So we need to do a cryopreservation by doing an ovarian tissue. Or if I know that there is a cancer patient, but she doesn't have 2 weeks or 3 weeks at hand, I want to start a chemotherapy, radiotherapy the next 48 hours. In that case, the best option would be ovarian tissue cryopreservation. The reason is that we do not require ovarian stimulation drugs. We do not need her to be single or have a partner. And very important that we also understand that they're the best means to cryopreserve because primordial follicles are least sensitive to cryo injuries, unlike the ones which are primary oocytes or secondary oocytes. I just want to share you some landmarks which have developed in the realms of ovarian tissue cryopreservation. The bits that I would tell you that actually in animals we were doing all these procedures And this happened in sheep, and successfully in 2000, the first, successful orthoptic human transplant happened from the frozen, thawed ovarian tissue. And this was actually in the US. But the first baby that was born from ovarian tissue cryopreservation in the human beings was actually by the Belgian groups. And that's where the story turned. And in 2015, it was Octay's group which actually started in the US. They later on went on to give the first baby which is born from a robotic transplant. That means they cryopreserve the tissue and they put this back in a transplanted in a minimally invasive surgery. And I will tell you, these are the future developments. So the first ovarian tissue cryopreservation, as I told, was actually Octay who started it in 2000 in New York. And Professor Octay's group could not report the first pregnancy, even though they did the first transplant, but it was the Belgian group, and this is the lady who came from the Brussels group. And subsequently, it was Professor Myro who also reported in 2005. So if we look at the global scenario of ovarian tissue cryopreservation, you will see it's US, which was leader, countries like Belgium, France, and Nordic countries, Denmark, which has taken the lead. World over, I think countries which are going ahead is Japan, because they are the ones which are again pioneered, and in Australia. So these are some of the centers which actually initiated almost at the same time in the early 2000s. And therefore, this procedure has taken up, and today we have reported over 200 live-born babies from ovarian tissue cryopreservation. However, the number of ovarian tissue cryopreservation women have undergone are close to 8,000 plus. So, if you look by the committee opinion of American Society of Reproductive Medicine, while embryo oocytes and testicular cryopreservation have become very established methods, ovarian tissue cryopreservation was initially considered experimental. But if we look at the latest guidelines which have come in 2019, this procedure is no longer experimental, because they have on record more than 200 babies. And I think in 2025, there certainly will be more, because these are not reported individually, they come from registries. So today we look at worldwide from the initial graph. You look at how many countries are reporting. India reports 3 centers. This, if you look downside, these are the number of centers which are offering ovarian tissue cryopreservation, and you look at it, in India there are 3, and we happen at aims to be one of the center. We take pride in saying that we are one of the 3 centers which are reporting ovarian tissue cryopreservation from the country. So what are the means to get the data? These are few of the global registries to which people report babies that are born, and therefore data comes from here. Now, I will not tell you much, but these are all the stories which came in Nature, in NEJM, and the papers when the first live-born babies were born. And I think we should also be reporting sooner, in a few years from India, a baby being born of ovarian tissue cryopreservation. Now, basically, we have to understand that this technique is basically being tried in cancer, but now we are moving beyond the borders of cancer, and we are offering it to girls who have got even Turner syndrome and many. So let us look at who are the candidates who deserve ovarian tissue cryopreservation, which is one part, and then transplantation. Is it just cancer? Yes. Cancer is the first leading cause of any woman where her ovaries at risk of being damaged by gonadotropin chemotherapy or radiotherapy. But besides that, there are a lot of conditions which now, with our better understanding, have the option, especially when there is a young girl who has beta thalassemia. She's got galactosemia. It's an inherited disorder, but if she grows, her ovary will be damaged. Girls with Turner's, by the time you realize that she's 15 years, her ovaries are all gone. So it's better to do them in earlier stages. A lot of young girls who need autoimmune therapy, because that will spoil their ovaries. Presently, we are doing it and we are offering it, and we will show you a video also of a young girl who was undergoing bone marrow transplant, because when you do bone marrow transplant, you're giving very high dose of radiations, whole body radiations, that will completely knock down that young girl's ovary, and therefore she's a good candidate. Also in cases of borderline ovarian tumors and ovarian torsions, though there are only few case reports. And any disorder which leads to premature ovarian insufficiency, like the genetic conditions, and also endometriosis. There's a lot of work coming on ovarian tissue cryopreservation from Israel, and there are leaders in women who got, or young girls who are diagnosed with endometriosis. So these are all the conditions that I've shown you who are at high risks of premature ovarian insufficiency when they get these chemotherapy, and the doses are the ones which help us decide, or they are the ones who are at intermediate risk. That means they're going to get this much of radiotherapy, and therefore, whenever we get a referral, we first ask the radiotherapist, we ask the chemotherapy you're referring consultant from the medical oncology, because cyclophosphamide alone is not scary. But if the girl gets up to 2 to 5 grams of cyclophosphamide, she definitely stands in the high risk. So all cyclophosphamide is not bad. It's important to know what exactly dosage she's getting. Likewise, as I told, genetic disorders, autoimmune disorders, and when we are doing stem cell transplants. Now, when I talked about the topic is procedure and techniques, I think that's where the catch is, and that's what is exciting, because if we look at, there is no standard guideline. Like you have stimulation protocols, you have embryology protocols, you have KPIs. We don't have anything here. We are just hit and trial, and every unit has its own protocol, and we are also being learning from others. So selection criteria is a little variable, which depends on a lot of discussion between your referring doctors. Laboratory handling is very important because every lab has got its own way, and we also contacted a lot of centers in the US, in Europe, before we took our decision to decide what is a size and what is a freezing protocol. And very important is how will you transplant this tissue back when this girl comes out of remission or when she needs to have a baby. So to tell who are your women who are best suited, this is a very nice criteria, which first came in 2005 and then was revised in 2014, which is called the Edinburgh's criteria. And here, if you look at it, there are definite criteria. You will never offer ovarian tissue cryopreservation to anybody who is older than 35. However, there is a gray zone between 35 to 38. They say yes, depending on her reserves, depending on her AMH. But for beginners, the best results would come at anybody lesser than 35. Of course, what is the dose of gonadotoxicity you have to decide? What is the long-term survival? That I've already said. Also, we must know that she is negative for the infections. Be willing to give the informed consent as if she understands. And in a child where consent is not there, it is an assent, it is the parent. So there's a lot of medical legal work that is involved, and somebody who does not have any existing children. These are the criteria for cancer patients. So if you have a child, I don't think it makes sense to undergo this intensive procedure. So I just thought I will just show you this video of telling you how we go about. Now, this was a girl who came to me. She was an 8-year-old girl, but if you looked at her, her physical height was just of a 4-year-old girl, stunted, thalassemia major. She was getting blood transfusion. This girl came from interiors of West Bengal. Her parents were not educated, but they were told when they came for bone marrow transplant that your girl will lose her fertility and she will become amenorrheic. And then they came very innocent parents, and then when we advised them, and you can look how small her ovaries were. When we got her on the OT table, we could hold her in our lap. And simple procedure. I just wanted to show you that this ovary was one of the smallest ovaries. But when we did our ovarian tissue, cortical thickness were made, and when we looked at this tissue as part of our grant, we found this had the best yield of follicles. Now, this ovary was so small that it came through a 5 millimeter side port. As against another video that I will show you as I move forward in the next slide. Now, this was another girl who had a little bigger ovaries. She was a case of C. rectum undergoing radiotherapy, and you can see her ovaries, and she was, I think, we didn't have time. They want to start. She was, I think, 16 or 19 years. I'm not very sure. We'll show you the table and we'll share. And this ovary is relatively bigger. You can see it. So removing the ovary on the laparoscope is again a challenge, because when you put these ports in small girls, you need the help of your pediatric colleagues. To place the ports in a 4-year-old child or a 5-year-old child, it is not as simple as you place in an adult. So we take help of our colleagues. But see, this ovary is slightly bigger. I want to retrieve this ovary with as little damage as I can do when I retrieve it. My handling technique will be as simple. You can see we hold with soft graspers. And when we even draw it up, we took this out through a 10 mm port, because we knew if I got it through a 5 mm, it would actually be damaging at the best harvest. So we withdrew it from a 10 mm port, and this was rather easy. Now, I would just talk on the procedures, and I would share you that the big challenge comes when we are getting the tissue. And I will again share you that as you advance into experience, this was yet another girl. You can see she was 22. She had Again, C rectum, the radiotherapy had to be started immediately. Very poor girl, family was very poor, and they knew that they could not afford ovarian stimulation, time, and also the money. But here I want to show that these are some of the later cases that we started developing and we had understood, because this is what different groups do. Denmark group, where we learned and we went, I took help from the faculty there. They believe in cryopreserving the whole ovary, cutting slices out of that. But the Belgium group, who are way ahead, actually say that you can still remove good amount of sizes of ovarian cortical tissue. And this is what we do: remove them, slice them, and then subject it to finer pieces. But as beginners, when we started the whole technique, and still also we would rather remove in prepubertal girls, not small slices, and even in adults, I would always recommend people to go and remove the whole ovary. So these are some of the fine-tuning things that I would want to share with you on the removal of the ovarian cortical tissue. Now the next step is in the procedure is about handling the harvested tissue that you've removed. So you cut small slices, and I have a brilliant girl who's doing a PhD with me. She also spent a lot of time in the initial 6 months. We actually gave her ovaries from menopausal or uteruses or undergoing hysterectomies, and she learned, because the art of slicing is very important. What you do is that you cut slices which are just 1 millimeter in thickness, just 8 to 9 millimeters in their size, and that is a brilliant catch. After which you would subject them for either slow freezing or vitrification. Now, in the process of slow vitrification and because my slides are in animation mode, therefore I think I will take this higher. So definitely, the world over technique is slow freezing, except for Japan, which believes in vitrification. Though it may sound easy, but actually the number of babies that have born world over have actually come from slow freeze. Very few babies have been born from vitrification. And in our experience also, we want that slow freezing is a better technique. The only problem is that in a slow freeze, you need a different kind of a freezer, which I will show you in a video. And then you are able to produce a better outcome. That's what literature says on even meta-analysis. What's far more important, we don't have any defined media that is available. While we use a Kitasato kit for vitrification, which is coming from Japan for vitrification, we have to understand that this media is yet not standardized. It is still very toxic to the tissue. What you use for vitrification of oocyte is not the same media, because you need, there the technique is quick and out with high concentrations, as embryology people will say. Shorter durations, higher concentrations. But what is important is cells versus tissue. The physiology is very different, and therefore that's what you have to understand. But what's the catch here is, when we are doing it, you have to understand in slow freeze, we actually need to make. So we make an in-house media. We've learned the recipe our way, and we are quite happy. We have standardized, and we are happy to share that recipe, which Spondita uses because she needs 1 day to prepare. So if we look at it, slow freezing is considered the most appropriate method, as more babies have been born from them. Now, coming on to, I thought I'll share you this video of how things go. And this is the ovary of the small girl, that the one who was thalassemic, looks so small. And in this, we cut slices as small as this. These slices are then put in the media, and I will show you, this is exactly the cryo-bio system. Now, there are 2 companies which are only making, the cryo-bio system is made in France, and we have a defined protocol, which we have also learned, and then we put them in the ice bath. There's a way of putting this, tissue in the media at a set time. You rock it for a, you just try to put on those rockers, try to shake slowly, and then we follow the protocol which is there, which we have again changed a little bit on the vitrification, slow freezing on the cryo-bio system. And the procedure itself takes around approximately 2 to 2.5 hours, almost 180 minutes, and then the things are put back in big cryo cans. So that is all about how we do the procedure. Now, again, as I said, slow vitrification or freezing, these are the 2 options. But when you do, you need all these big machines with the slow freeze as compared to vitrification. But at the end of the day, the vials that store the tissues go into big liquid nitrogen tanks, which are a little different from your standard tanks. Now, this is what looks simple, but the big challenge is that you have to put this ovarian tissue back into her body. And that is when you will put her when she's free of cancer, A, B, when she's grown from a pubertal to post-pubertal, she's reached a reproductive age group. And secondly, we prefer to put it when she's desiring of a childbearing, because we know that these grafts, when they're put back in the body, they have a shelf life. The life is about 5 to 7 years. So you're not exhausted by putting in a girl who doesn't have any intentions of marrying, because at the end of the day, this is to be harvested, stimulated, and creating a baby. So what are the sites that you can put back? We put back these transplants into the pelvic cavity, which is called an orthoptic transplant, or outside the pelvic cavity, which is heterotrophic. Now, in the pelvis, we either put it on the surface of the ovary, from which you would actually remove, like you did ovarian tissue cryopreservation, by cutting the slices, or the best, when you remove the entire ovary, putting them back in the peritoneal windows. You create it, and I will show you how you do that. So if you look at internationally, most of these transplants are happening orthoptic, because we know that if you put back in the anterior abdominal wall or heterotrophic over the anterior abdominal wall or the forearm, then there is a risk of more ischemia. The vascularization of the graft may not be as good. However, babies have also been reported by Octay's group. Their first baby came from a heterotrophic transplant. Now, very important, ovarian tissue transplant is more challenging than just cryopreserving the tissue, because what you have to tell the family is how will it work, because you just can't do an OTC and get away. You have to consent or assent them for the future, because we know that when we do an orthoptic, it is more favorable because it gets better vascularized, and also the development of this transplant is taking place in the pelvis, in an environment which you will be better to access when you do an oocyte pickup, when you're stimulating that lady. And also we know that this is something which becomes easier for us. If you do a stimulation, then it is not easy to retrieve that oocyte from the anterior abdominal wall. Now, again, very important, while they have a life of around 5 to 7 years, the transplanted ovary actually takes time to be maturing or to be adopted. That means to vascularize and give its effects in terms of endocrine benefits, or also developing mature follicles, it takes an average of 4 to 5 months after a transplant. So this is all what you should tell the family, tell the girl, that look, I put a transplant, it will not start working the next day. It's not like a kidney transplant that after immunosuppressants, it has to take its function. Here, it takes longer. So this is one of the papers that I want to say, which has come from Marie-Madeleine Dolmas, the group which reported the first pregnancy in the world literature in 2004. This is a consortium, and this is an article which is coming from all the leading 5 centers. And I had the pleasure to work with Marie-Madeleine Dolmas and also in the French group. So I know that they are doing ovarian. France has been doing, Catherine Poirot has been doing ovarian tissue cryopreservation from the late 70s or early 80s. Though they have not reported the first baby, but testicular cryopreservation is a very normal procedure in countries like France and Belgium. So this is how, you transplant it on the surface of the ovary. I know it is not is it seen better now? Is it moving? Hello?
Yes, ma'am.
Hello?
Yes, ma'am. Yes, ma'am.
Thanks.
Perfect.
If I zoom it, can you see it better? Because I'm missing on. See it now.
Yeah, we have kept it.
Is it moving?
No.
Is it moving?
No, ma'am.
Okay, though I have to go back on that initial one. So if I know my slides are not very seen, but if you see that on the surface of the medulla from which they removed, they are putting it back. And this is how you put back those ovarian tissue pieces that we are actually, and then you cover it with some kind of, cellulose or some material, because you want it to stay there. And then you see the other films which are showing that you open a window in the broad ligament and put it back there, and then you kind of close it. Very important, the very important catch, and why people have moved to very fine sutures and robotic surgery, is that how the graft takes back is how you put this tissue back. So a lot of people do a laparoscopic removal, but when they put this tissue back, they prefer a laparotomy, because they say that you do not get such a good tissue handling as you would get in a laparotomy. And they use something like 70 or 80, suture materials as 8090 silk, what you use in the eye surgery. And therefore, the reason is that when you do little damage, your ischemia is little. But I will show you some pictures and some literature where Professor Octe's group is now shifted completely to robotic surgery, and they have really improved the outcome. So this is the way the tissue is put back. So when you do the tissue replacement, when you do a transplant, you can follow the patient by the resumption of her periods clinically, improvement in her menopausal symptoms, and also spontaneous pregnancy. Trust me, of the more than 200 pregnancies that have been reported, 40% have occurred naturally. They have not needed IVF. Yes, hormonally, we need to follow them up. We follow them with FSH and AMH. And these are some of the graphs which show that it takes up to 150 days also in some patients for the AMH and FSH to decline and AMH to start showing a rise. Now, what is the success of an OTC? And these are all papers which have come from literature. They say that ovarian activity will be restored in more than 95% of cases after. The duration that a graft will last is 2 to 5 years. Therefore, we prefer to remove the whole ovary because you have the whole ovary, and in one patient from whole ovary, you can create up to 25 to 30 slices if it's a nice size ovary, even in young girls. And you can put 2 to 3 at a time. So, you know, she wants one baby, she can even go back to have another baby because that's the way she can try. Or first time, if the graft doesn't get vascularized or if it doesn't kind of resume, you have the chances of putting back more grafts. Now, 29% of pregnancy is the one which is reported late. This is an older paper. I think now the results have improved. And this is the later paper which has come in 2020, which say that the live birth rates have reached 6% to recently 41%. This was the US group which reported their, rates of live birth rates after reimplantation from frozen thawed tissue. So definitely very, very impressive now. I'm sure this is better than what we would get from even oocyte cryopreservation in cancer survivors or even embryo cryopreservation. Now, the big thing is, can she have a spontaneous pregnancy? Yes, there are spontaneous pregnancies. As I told you, there have been pregnancies reported spontaneously. 40% patients, pregnancy rates after spontaneous have been 40% as against IVF. And also, there have been higher, but the big problem here is that miscarriage rates, again, were higher with the IVF. Probably that's the reason why live birth rates are lower with an IVF outcome. And if you look at it, if you compare that when they do an embryo culture and they do an embryo growth in a, oocyte from an OTC ovary versus any other woman, the protocols and the outcomes are comparable. So there's no difference as such, because these ovaries are reimplanted and they behave like a natural tissue. So these are some of the live births which have been reported after ovarian hyperstimulation. But the beauty is that I will share you what are the other things that you can do when you do an OTC, can you do an IVM. So on the current status, we know that it is no longer an experimental procedure and you can offer it provided you have all the resources and you have the complete team. So before I really talk to you, I would want to tell that it looks nice and simple, but there are a lot of challenges because we are now almost 4 years in this whole procedure and we feel that there is a challenge every day, right from getting the patient's referral to counseling her parents to the technical issues. And I know that I have not done any OTT now, but I will face those challenges in the next 2 to 3 years in my, in our hospital. And therefore the challenges that I want to show is that we have to realize that we are using, and that's not India, we don't have big data now. But when I talk to my colleagues who are doing it, and that's the Manipal group, us, and maybe another group in the south in Chennai, we also share this data. If you look at it, 8,000 women, over 8,000 women have stored their ovarian tissue, but only few have actually used it. So it's a story that a lot of them store it, but few consume it. So it's actually a lot of wastage on the resources because you are doing a procedure, you're involved in your theater, your anesthetist, all the lab, and then we don't know how long we'll be able to store them. Again, the challenges, as I told you, of the ovarian tissue is when it's transplant, ischemia, because you know which graft will vascularize, which will not, we don't have data. And there's a lot of genomic study happening from the animal models to now human models to understand some genomic background to why some transplant take up, why don't. And also, we are worried about the risk of malignant transplant if there is a lymphoma leukemia. So if it's a lymphoma leukemia, we prefer to get a PET scan done and check that the ovary is not involved. Only then I would like to do. Now, can we improve? And I'm sure the embryologists would have better answers. Can we use, and that's what some centers are using, they're using, instead of normal nitrogen, slash nitrogen, which you know is better results. Some procedures like scaffolding, and I will share you what scaffolding means. Of course, in the US, some centers don't put back transplant at laparoscopy. They only use robotic because they feel that the suturing ability of that thread is much better on a robot. And also, newer procedures are coming up in which, again, they are in the process in animal models to do an artificial ovary or not, which is called, organoids. And maybe when people are putting back the ovaries, they're using some vascularization compounds like VGF compounds. There are 3-4 compounds which they have tried, but they're not sure. Now, can we combine the procedure? Yes, when we are doing at our center, we combine the OTC with IVM. That means when you're cutting the slices, you do get immature follicles. You must have seen the video I showed you. When we were cutting a slice, there was an immature follicle come. So what Spandita does is, my embryology, she's dedicated to this work. She aspirates. First thing is she washes it in the media and she immediately starts aspirating some of those follicles which are there. She gets those immature follicles and then she grows. Again, this media is homegrown. She's prepared an IVM media which is homegrown and she's able to now even she's done it in animal models. She's done a lot in rat, and she's now trying to develop that media and move forward in human models also. The other procedures, I don't have experience. There are data which says you can use OTC after over in mild stimulation and things. But if you look at the guidelines, they do not advise you to mix. Other than the OTC with IVM, others are not recommended. So this is how you do when you're cutting this ovary. You do I have time or have to complete my lecture? Am I going far? Have I overshot my time? Prara, can I speak further?
Yeah, ma'am, you can further. You can go ahead.
Okay, so when you are like, this is the way we do. When we see that we are slicing, when we see these follicles, we aspirate, and then these immature IVM are then put in a special media. We put them to M2, and then we cryopreserve them as mature oocytes. So I just want to share that what scaffolding means. Scaffolding means you are putting these ovarian tissue on some biosafety tolerable materials, and these are the ones which a lot of Professor Octay's group has done, and they've pioneered. They're using a lot of these growth factors on, cellulose and other material. And then on these, you layer down your ovarian tissue and then freeze them. Because they say that when you are doing this procedure, you can see this, that these tissues have been put on some cellulose material. They are stitched finally, and then they have kind of put, and this extracellular matrix that is called alloderm, which they are very happy, and they say they gives better results and allows the dissemination of some of the growth factors which they process during the process of slow freezing. And then when they take this tissue out from the scaffold, they say that these ovarian tissues are better to transplant. So there's something which is called 3D scaffolds that they're using as we use scaffolds in our building material. And as I said, robotic, this is some of the best data which comes from one of the centers in US. They have also said that these are showing better results in terms of using extracellular matrix plus robots. And they have published their case series of around 10 to 12 cases where they've shown that the women, in fact, 50% of these young girls actually had pregnancy, which is a very, very good number. And most of them are spontaneous pregnancy. So they say that this is the best way to put the transplant back. Now, of course, I think it's a very big challenge. So anybody who starts, I think you have to really consider. It's not ki kar diya and chhod diya. We take almost a week talking to the family. It doesn't come very easy, especially when there is an 8 or a 9-year-old girl. Family doesn't understand. And the consent forms are not what are coming from the ICMR. We have developed our own forms which relate not just to the procedure, the anesthesia, the freezing, but go on not just to the OTT, but also what will be the future. So that is very important, and that is what you have to understand. Of course, the very biggest challenge for me, at least sitting at AIMS, is referral pathways. I feel very upset when a breast cancer survivor has spent 3 months roaming with my surgeons and the radiotherapist and the chemotherapist, and then she says, "Doctor, I have been told I just have 5 days at hand. In 5 days, what will I do? What did you do 3 months?" Because my surgeon colleague, my radiotherapy, my medical oncologist does not realize the day she is diagnosed breast cancer, I could have talked to her, consented, and cryopreserved her embryos or oocytes. And that's where I think our oncology referrals come very late. Perhaps we're a big hospital, everybody is too busy in too many things. But if you have a small setup or you have good liaison, I think you all can do a better job. And this is the model of care which HRA says, so the team should not just be a fertility specialist, but you should have counselors. And I think we do not have this privilege. We are also psychologists, we are also counselors. And these are my referring people. I get a lot of referrals from hematologists actually, who are now aware. I get them, they are my best source, and also from my oncopediatricians who give me the highest number of cases of Ewing sarcoma and others, because they know that the girl at 7 or 8 years will lose, because Ewing sarcoma's chemotherapy is most deadly, and I get the best reference from my pediatricians and my hematologist. So this is a bit of data that I want to show off. We have got an ICMR grant which is just about to complete, and this is our primary objective where we are comparing, and we will now be thawing the tissue, because a bit of the tissue we have kept for research, in which we are not only looking at the counts, the viability of the primordial follicles, we are also looking at the DNA damage by flow cytometry, and we are going to compare another outcome where we are looking at creating culture media of IVM in-house using mouse ovarian tissue slicing. And we are using the criteria. Our cutoff is not 5-year survival more than 50, but I have taken 5-year survival of more than 80%, because we are spending a resource which is limited coming from a grant. And this is how, as I showed, Spandita cuts the tissues in thin slices, and then she removes it from the medulla, which is again a big effort, and then you get nice slices, as you can see, and then we put them. So as of now, we've done 24, 2 have not been added, and you can see we have a mix. We've even got young girls with CA vagina, CA endometrium, she doesn't have time. We have adenocarcinoma of the rectum. CA rectum is the one which we get a lot of referrals, no time, she needs to start. And you'll see that there is, in fact, I have just put, I think, 1 case of thalassemia. I've done 2 cases of thalassemia, and we get these. A sex spot tumor in the young girl in the ovary was also there. And they're all the ones who don't have time, and they're willing to. And this is what we do when we are subjecting them to, Spandita is now assaying and analyzing, and is part of her PhD, which she will be presenting in this year and completing her PhD. So what is the future? The future is there. There are a lot of work which people are working, whether they'll get ethical clearances or not, especially when it's delaying aging. Now, there are a lot of work which is happening in some parts of the world, especially in Nordic countries, where they're saying, could you save her ovarian tissue when she was young and then put it back when she was menopausal, because she would delay her menopause and also stay young. So we do not know. These are some of the case reports where we know that in a young girl with Turner's or Turner's mosaic, you should do these cryopreservation when they're just reaching before 10 or 12 years, because that's too late. At 3 years and 5 years is the best time to do OTC in these girls. And also some of these elective, procedures are said to prevent age decline. I will just cut it short here that there is some work which is happening on preventing ovarian contamination by creating what is called as using in vitro growth factors to create an artificial ovary, but these are all animal experiments. We still are a long way to go when it comes to human, ovaries or creating artificial ovaries. But what's important is that, we are trying to, create engineered in vitro culture again in animals, whether we reach it in human beings, but there is always a hope. And that's what I say, that the future will be probably artificial ovaries, which they are doing by scaffolding and using polymers, as I would tell you from the literature. I am not a molecular biologist, but these are some of the attractive futures that most of people who want to follow research will look. So I'll just conclude that OTC is no longer an experimental. What it really needs, not just the embryology or a laparoscopy, but a very good multidisciplinary team, which should include your oncologist who have, trust me, when I started doing it, my hematology consultant and my colleague who's a professor, heads pediatric oncology, came and watched me. She wouldn't send me patients. She watched me. And then she sat with my embryology technicians. She saw that we are not playing a joke. And when they both were convinced, then they started referring. So actually, you have to tell them to come in to get convinced. And that's where your strength is. Of course, you don't need just infrastructure, you need skills. And you need a very dedicated team, because to do an OTC may be simple, but that half an hour procedure on removing the ovary actually takes 1 week or maybe much longer to convince the family. And of course, this may be the future when we look at cancer survivors in young girls. So of course, in India, we are got a long way. We need to create awareness. We need to train our colleagues and even share. I don't want to say that I have made the media. I'm happy to share the media that we made. Why should we shy? Because we also hit and tried and learned it. And I would just end my talk say that collaboration is the way forward. Sending referrals is the way forward. And that's how I would believe in growing. So thank you very much. And I would like to thank all my colleagues who are there, my pathology, my colleagues in pediatric surgery, and all the people who helped me. And these are some of the pictures from whom I worked, including Mary Madeline Dolmas and Irene, the mistress, who are world leaders today, who've created first babies. And these are the centers where I went in France and Belgium and other parts of Europe. So thank you very much for your patience.
Thank you, ma'am.
I'm happy to take questions if you have any.
Thank you, ma'am. All of us are here Amol, Dr. Sumanna, Monica.
Hi, everybody. Hello. Oh, you guys are looking so smart and handsome.
Hello, ma'am.
Hi, Monica.
Hi, ma'am. We missed
Oh, hi,
you.
Sumana.
Ma'am, it was
No
a
more
nice
questions
lecture,
from
ma'am.
me. Question mat puchna.
No, thank you, ma'am. Thank you. Because there is a workshop at
Thank you,
AIMS
thank you, thank you.
this weekend, and ma'am
Yes, we
was
are
busy
looking
with
forward
that
for you. We are
workshop.
preparing for the aims.
Still, you took
So we
out
are
your
waiting for
time,
you
ma'am.
people for tomorrow.
Still, you took out
Yes.
your time, and thank you, ma'am. We enjoyed the lecture.
Yeah.
Thank you,
Thank you,
ma'am.
thank you.
Ma'am, it was so nice, and thank you. We are still reviving the memories we had at the alumni meet. Thank you for that,
Yes.
and enlightening lecture.
You
Thank
all
you.
made it a big hit. Thank you so much for coming. Thank you. Thank you
Thank you.
so much. Okay, bye.
Okay, thank you, ma'am. Actually, didn't introduce ma'am. For you people, ma'am is at present HOD of AIMS New Delhi, and for us, she's teacher to all of us. So actually, I always say that a teacher's best CV is his or her students. If they are doing well, that means he or she taught us well. So that's why we didn't keep a formal CV for ma'am, because it's very difficult for us to describe ma'am in 2 or 3 lines. She's always a very good teacher. So you listen to this new concept of ovarian tissue cryopreservation. These are relatively newer concepts. And now there is one more talk left in the embryology session. We'll go through that. After that, we'll have lunch, and then we'll start the clinical part. I think for you people, clinicians, that will be more interesting one. So Parag, call upon the next speaker.
For our next session, I would like to call upon stage again Dr. Charujat Joshi. One session is left for the embryology section.
Again, good afternoon now, and I know all of us are waiting for lunch, but believe me, you are going to hear again one fantastic lecture by one of our other colleague. She is senior embryologist attached to full-time freelancer, more than 8 years of experience, 4 review articles and 2 research articles, and she has done poster presentation at COGI Lisbon, poster presentation at many national conferences, IFS Young Achiever Award, first prize in poster presentation at IHERA, panelist in various national and international conferences, and she has specialization or special interest in genetics. So Ms. Pratyushtha Mishra, she is a ASRM certified embryologist. So over to you.
Thank you so much, sir, for introducing me. I'll start my slides. So where are the slides? Okay. Yeah, got it. Yeah, got it, sir. Okay, so good afternoon all. So my topic is conventional PGT versus NI PGT. So we all have already discussed what is PGT, what is the conventional method that we have been followed since so long. PGT is the short form for pre-implantation genetic testing, and generally we do it on a daily basis for aneuploidy embryo screening. So it's a technique used in assisted reproductive technology or ART to assess embryos for chromosomal abnormalities before implantation, just to avoid, just to test whether the embryos are aneuploid or euploid or mosaic. We generally do this embryo biopsy. So traditionally this involves trophectoderm biopsy, which is the outer part of the embryo, where a few cells, more than one cell is enough, but we generally take out 3 to 4 cells are extracted from the embryos. And recently there has been a new approach to this, which is NIPGT, or non-invasive pre-genetic embryo testing for aneuploidy. We call it as NICS. This is the diagram. Sir has already shown the videos how to do the biopsy, so I'll skip this part. And these are some facts about this PGT or PGTA, we can say, to screen embryos for whole chromosome abnormalities or the whole genome screening. So PGTA helps to shorten the time of viable pregnancy by reducing the need of multiple IVF cycles. So if we can get to screen the embryos beforehand, so we can skip doing multiple cycles, multiple pickups for the patient. And embryo transfer, obviously we'll do it before embryo transfer. If the patient has already, patient is having so many failed cycles, we can go for that. Maternal age, paternal age, whatever is there, any difficult samples we get, even if we are getting good embryos, the embryos look good, but there should be some reason that they are failing, getting pregnancy and all. So we should do PGTA. We should counsel them for PGTA, in fact. So sometime it may use to take mosaicism, because as I said, there will be 3 results: euploid, aneuploid, or mosaicism. So generally, doctors and embryologists do not prefer doing transfer of the mosaic embryos, but I personally have seen many results, positive pregnancies, and that too also viable pregnancies that lasted, and even live birth we have seen with mosaic embryos transfer. Then next gen sequencing, this is the same thing. And some facts about PGTA, that all cells in an embryo, in any embryo, does not demonstrate aneuploidies, that is a chromosomal abnormality. So there are only small number of cells which shows abnormalities. If embryo biopsy shows abnormal DNA, it is not the whole genome. So as I said, we are taking out 3 to 4 cells generally from the trophectoderm, which forms the placenta, not the ICM. We are not disturbing the ICM, obviously, in that invasive method. So maybe those 3 to 4 cells will be aneuploid or mosaic, and the rest of the embryo is, euploid. So this is the difference why gradually we are moving towards NIPGTA nowadays. So some facts also, again, this is the blastocele, as you can say, and the trophoblast, 3 to 4 cells we are taking. So it is also observed that abnormal cells often self-destruct and some cells self-correct by themselves. As I said, we have seen positive live births with mosaic embryo transfers. That's because some cells have self-correct themselves. So the cells, it's a very unique thing that human cells do have the capability of self-correction. So there might be a chance that the embryo self-correct itself. And again, if we are transferring mosaic embryos, there is this chance that we have to, if the pregnancy lasts after 3 months, then we should do amniocentesis. That is an additional thing. But we are discussing here about PGTA. So for PGTA, embryo biopsy is taken from the trophectoderm. This shows that there is no benefit of doing blastocyst stage embryo biopsy, as cells which are tested are from the outer layer. We are here not disturbing the ICM. And the indications would be repeated implantation failures, repeated pregnancy loss, advanced maternal and paternal age. That means if we are getting very bad samples, semen samples, or oocyte quality is very poor, then male factor infertility, again very bad semen samples. Then genetic disorders, if the parents are having any kind of genetic disorders, then we should go for PGTA. So that is a conventional trophectoderm biopsy. Accuracy and predictive values this the trophectodome biopsy combined with next-gen sequencing, it has shown that it generally takes 15 days to get the results. So it has been shown to be accurately identify aneuploid embryos. But as I said, there is this chance that those cells we are taking out, maybe those are aneuploid only and the rest of the embryo is euploid. So we can do additional testing with that if the patient wants. If we got 4 embryos and like we are getting 4 embryos and all the embryos looks good, of very good quality, but all are aneuploid. So we should do additional testings like NIPGT or NICS to just to know whether those cells are aneuploid or the whole embryo is aneuploid. So I have a concerns about the clinical utility of PGTA persists due to inconsistent finding and the potential discarding of viable embryos. That is the additional testing as I mentioned. So safety considerations, obviously experience that the embryologist we were discussing beforehand also, that the experience should be there of doing a proper biopsy, clean, like everything should be well prepared, laser, everything. Loading of the taken out cells, trophectodome cells should be done perfectly. Then there is it's already mentioned here, when performed by skilled embryologists, theoretical concerns remain about the potential impact of embryological, because if we, if we'll, even in the loading part, we do any kind of, any kind of fluctuation is there, then also we can, our result can, that can also hamper our results. Now we'll discuss the NIPGT. As I said, it's the non-invasive method. Nowadays, it's in like very much use, because already we have discussed that trophectodome cells might be, there is the scope of that the whole embryo is good, but only those cells are carrying the aneuploid chromosomes. So this is also we call it as a NICS, and methodology is where cell-free DNA, where the I'll simply describe this, that we culture the embryos up to day 3, whether we are doing it in a group culture or single drop culture. Then on day 3 we'll change the media, we'll prepare on day 2 that dish, then we'll 25 microliter for each embryo. Then that thing will culture those embryos in those droplets for day 3 to day 5. Then we'll freeze the good blasts, and then we'll take out the media. Around 23 to 24 microliter media we'll take out, and those media will load in the PCR tubes and give it for testing. So that is the technique. And overview, obviously the same thing, what are the indications for PGTA, we are considering the same things for if Down syndrome, Edwards syndrome, any kind of chromosomal abnormalities are there with the parents, and age group is very higher, different, like difficult samples. In those cases we can go for NIPGT. So the plus points, the difference between PGT and NIPGT is we are diagnosing the cell-free, we are testing the cell-free DNA. That means we get an idea of like whether the whole embryo is having aneuploidy or any chromosomal abnormality, or whether it is mosaic or not. And so it is safer. The like biggest point is it's very safer than the traditional PGTA method, because we are not, we are not applying laser, we are not taking out the cells. So it's very much safer than that. It's a non-invasive method. So patients undergoing IVF often worry about their embryo biopsies. So they patients ask a lot of questions, whether my embryos will be fine or not. And here, as we were also discussing, here we are skipping that part. Again, like freezing, thawing, and at least 3-4 times freezing, thawing we have to do with PGTA, which we are skipping it here if we are going for fresh NICS. So embryo biopsy requires higher skilled embryologists. So here we can manage with a lesser training, embryologist can easily adapt to this technique. So who should get the indications? As I said, it's very much similar for the conventional PGT. Women who received abnormal ultrasound results, then if the patient is having various failed cycles. Then the challenges with NIPGTA there is only one challenge, that we have, like, it's on, we are testing it right now. It's still there is a scope of that we can get some error. What is the error rate exactly, we don't know till date. So studies have reported higher rates of DNA amplification failure with NICS, so which is in poor correlation with trophectodome biopsy conventional PGT. And the clinical outcomes, we are still studying it. So one of the study reported a clinical pregnancy rate of 51.1% of euploid embryos and 28.6% of mosaic embryos with NIPGT. So it's still going on. Like there is a scope that we can get an error rate, but till now it's very much recommended by. Also in India, a lot of centers are preferring, they are moving to forward with the NIPGTA. So some research suggests that NIPGTA may offer higher diagnostic accuracy comparative to PGT, because here we are studying the ICM is also contributing to that genetic study. So ICM also is also contributing the cell-free DNA in that media, so it's more accurate according to some research groups. So for instance, a study reported that NIPGT demonstrated a sensitivity of 100% and specificity of 87.5%. So there is also this like according to my personal review, there is a personal view, there is also a error rate for the conventional PGTA. So this we can that this particular depends on the person, like varies from person to person what the doctors and embryologists prefer according to their practice. So in conclusion, so while NIPGTA presents a promising, less invasive alternative to that conventional PGTA, current evidence highlights significant challenges regarding its accuracy. So as in short, we still have the scope of research in that field. So it's a new field of research, as we can say, in accordance with our daily practice. So that's it. Thank you. I made a very short presentation.
So, thank you. Any question for her?
Anyone is doing NIPGT in India? How it is? Doing now? Everyone. So, what is the outcome in comparison to that?
I feel it's very much safer, and as it's very lengthy, it's a lengthy procedure. Obviously, PGTA, conventional PGTA is also a lengthy procedure, but
So they're only indicated once.
So we started in 2017 doing NIPCS, NIPGTA, and initial almost 200 patients we did where we did NICS and PGTA both to compare what we are getting, and overall in those patients we found that it was giving comparative results with advantage was as she very well enlightened that no biopsy is required, trained embryologist is not required, and overall it gives a picture of both not only trophoectoderm but also the ICM. So that is only one question I always had is it is said that when the embryo grows, it expels the aneuploid cells outside and the euploid cells are retained and they grow. That is what is said. So whether the aneuploidy rate with NICS is going to be more, means false aneuploidy, that is one question I always had. But in this study which we did not get anything like that. So after that we have continued doing NICS for last so many years. But of course, where patients are having monogenic disorders, structural rearrangements, known some disease, there you have to take a biopsy. There you cannot do non-invasive PGTA. So it is for a screening, yes, it is a good tool. So,
and even cost effective to some extent. Patients who cannot bear PGTA, they can go for NICS.
That will be included in the main video. But we are trying. Yes. We now the session will start for the live session for the biopsy. It won't be telecasted from the lab. We are trying on that, but I am not sure that whether that can be telecasted to here. Yes. And in between, you can, those people who can, you want to have lunch, you can have your lunch. And those people who are interested to see that, they can just change the dress and, go to the lab. So so anybody who is interested, just they can, yes, please. If one person also interested, they can go. Okay? You can go. Yeah. Lunch is started. Let the lunch start, and we will be doing that thing. So 1 or 2 people are interested, they can go inside the lab and they can see. That's it. And that's how you can see our lab also. Yes.
See, only 1 or 2 people. If everyone goes there, who is going to sit here and listen our clinical side?
The clinical side will start after lunch, and that's fine. Yeah. Before lunch also, you have to just 15-20 minutes. That's it.
Yeah, thank you everyone. Now we'll have our lunch. Please have it quickly and come back. Then the interesting part, because most of you are clinicians, we have tried to cover the basic parts like what to check before you start an IVF, then what will be the stimulation protocols, then how do we do a pickup, how do we do an embryology. There will be video demonstration of that. Because it's very difficult to take everyone in